Okay,
Sandhya.
please go ahead.
Okay.
Hi, Sandhya.
Yeah. So good
Can
evening,
we
everyone, and
Just
welcome to
wait,
the day three of.
just wait till she shares the screen and then we'll start. Nilima, please share the screen. Yeah, go ahead.
Good evening, everyone, and welcome to day three of the FOGSI ICOG online certificate course on infertility. And my heartfelt gratitude to our chairperson ICOG, Dr. Sheila Mane, Madam, whose strategic visions has continuously moved us forward. And a vice chairperson ICOG is Dr. Ashok Kumar and Dr. Sadhana Gupta, Madam. Our Secretary General, Secretary ICOG, Dr. Prateek Tambe, FOGSI President Dr. Bhaskar Pal, and Secretary General Suvarna Khadilkar, Madam, for giving us this great scientific feast on infertility. And it's a proud privilege to have with us Secretary General FOGSI Dr. Suvarna Khadilkar, Professor and Head of Department OBGYN, Consultant Endocrinologist and Gynecologist, Bombay Hospital Institute of Medical Sciences, Mumbai. She's also been the President of Mumbai Obstetric Gynec Society and Indian Menopausal Society and has received so many awards and a lot of publications to her credit. Welcome to you, ma'am, a distinguished leader in women's health, Dr. Suvarna Khadilkar, ma'am. Ma'am, you'll have to unmute, madam.
Yeah, thank you so much, Dr. Ritu. At the outset, I want to really thank Dr. Sheila, Dr. Ashok Kumar, Dr. Sadhana Gupta, and Prateek, who has, I've just witnessed the yesterday's webinar. I was watching the whole program and the very energetic panel discussion also I saw at the end. And I think the deliberations that happen during ICOG webinars are really very fruitful. It really helps everybody, and it is in fact the pre-test and post-test. You have got rid of the pre-test concept, so I'm very happy with that, because it is after you learn the fresh memory and the post-test how much you have learned, that is enough for assessing the knowledge that is imparted. And Sarita, I think you have done wonderful job last year when you were the secretary, and you are still continuing to deliver good job. And I see today's coordinators, Dr. Ritu Khanna and Dr. Kanti Bansal, as always, they are always doing good in all fields, especially in the field of ART, IVF, and ICSI. That is, I think, the focus on the day three of your certificate course. I think today we see lot of the new rules and regulations that come in this field. Everybody is so scared to even conduct the practice in their respective small settings, because you never know, suddenly a new rule will come which you are not aware, and then you have done something wrong. So I think these programs, webinars like this are very important to update yourself. And I can see the topics which are chosen are excellent. The patient selection and checklist counseling. And I also see the last topic by Dr. MC Patel, that is ART and Surrogacy Act. So I think this is what is very important, and all topics have been chosen excellently well, and I wish all the very best. I think Bhaskar could not join, he is abroad. So even he is encouraging all these activities, and therefore we have seen huge number of crowd that is joined, and it speaks for itself, the attendance that you are getting. Thank you so much for having me here. All the best.
Thank you. Thank you, Suvarna, madam, for your encouraging words and your kind blessings. Thank you so much for joining today. Over to Dr. Kanti, madam, for introducing Dr. Sarita Bhaleram.
Yeah. Good evening, everybody. And it's my great pleasure to introduce Dr. Sarita Balerao. And so we all know her. She's consultant obstetrician and gynecologist, Bhatia, Saipi, Reliance, HNH, and Bridge Candy Hospitals, Mumbai. Vice chairperson elect Indian College of OBGYN, Secretary Indian College of OBGYN, ICOG 2024-25, immediate past chair, AICRCOG West Zone, President Mumbai OBGYN Society 2021-2022, past President AMWI Mumbai branch, past Chapter Secretary Indian Menopause Society Mumbai chapter. The best things about her is she's ever smiling, so beautiful and so kind and soft spoken. So welcome, Dr. Sarita.
Thank you, Dr. Kanti, and it gives me great pleasure to welcome you all to this final day of this FOGSI ICOG online certificate course on infertility. My congratulations to Dr. Sheila Mane for organizing not just this program, but many, many wonderful programs this year. And congratulations to our dynamic secretary, Dr. Pratik Tambe, for this excellent scientific program, which covers many different aspects of fertility care. And I think you've also had a record attendance, which is really very, very encouraging. I'm thankful to the coordinators, Dr. Seema Pandey, Dr. Jairani Kamraj, Dr. Fessy Lewis, Dr. Monica Singh, Dr. Ritu Khanna, and Dr. Kanti Bansal. All the speakers of yesterday and the day before were really excellent. A big thank you to all the faculty, speakers, and chairpersons for giving their valuable time to the ICOG. So, as Benjamin Franklin, the famous politician and writer, once said, that an investment in knowledge pays the best interest. So, dear delegates, enjoy and learn and come back for more. Thank you.
Thank you, Dr. Sarita.
Yes. So now an honor to introduce Dr. Pratik Tambe, an IVF consultant and gynec endoscopic surgeon, Ashirwad IVF Mumbai. And we all know he's a very, very dynamic and meticulous secretary of ICOG. Over to you, Dr. Pratik Tambe.
So good afternoon, everybody. And we've had 2 excellent days of deliberations. On the first day, we had covered female factor infertility and fertility enhancing surgery. On day 2, we covered male factor infertility and IUI. And today is the PSR register, the best things we always say for last, and that is the IVF FOGSI and the advanced ART. On all 3 days, we've had excellent attendance, beautiful feedback. We had 800 plus people staying yesterday at 7 o'clock to do the post test, which is amazing. And it actually brings you so much good connectivity with normal OBGYNs, which we simply can't do in modern life in physical events. At conferences, our attendance have been dwindling. But I think through the ICOG platform, we are really blessed that all of us can connect to all of you individually. We can chat and we can share our knowledge. We can actually help each other to improve. We would seek your feedback and suggestions as to what topics you want us to cover in future as well. And Dr. Sheila Mane and myself will be happy to address those in future online events and the web series of the ICOG. I must place on record my gratitude to all the coordinators of all the 3 days, our wonderful faculty, and our 25 governing council members, many of whom don't practice advanced ART, but still they have made it a point to show up, be counted, learn, and contribute on all the 3 days. So thank you, all of you, my GCMs, and we look forward to seeing all of you in the audience at the ICOG annual conference, 21st, 22nd, and 23rd of August. Please be there in large numbers, and we look forward to meeting many of you physically there as well. Thank you, and let us begin with the academics.
Thank you, sir, for your very, very inspiring words. And I will move onward to...
I would just like to
just
say
share, yeah.
Yeah.
Yes, madam.
Yep.
Yes, madam. So we invite a very, very dynamic and very versatile chair ICOG. I think we are all having a wonderful, wonderful time. And that's because of you, madam.
So
it's all
nice,
your
so
vision
nice.
and your strategies. Welcome
Yeah.
to you, ma'am. Yeah.
Now I feel that I have too many hands. So many hands. Anyway, that is really nice. My GC is so active and all are actively involved, and that gives us also the encouragement to do that. Okay. And I must say, like I overall, I would like to thank each and everyone. Okay. And excellent conceptualization as well as the proceedings, what are happening. And I'm happy to know that there are so many questions already in the chat box that how can I become a member? So we'll share with you, Nilima, if you are there. I think people would like to know how to, I think, or if you go to website, you will get all the details. And we also have convocation in Bangalore. Dr. Sandhya was asking, yes, you can apply if you are eligible. We will also share with your certificate the criteria to become a fellow of ICOG. Member of ICOG, the criteria are different. Juniors can become member, the seniors can become fellows, and there are many advantages which are also mentioned in the flyer. We will share with you. And as Dr. Pratik said, that we are inviting you for all 3 days to Bangalore. And you please check your mail. We have sent a mail through FOGSI with the details. And Dr. Sarita already acknowledged. That means I know that everybody has received. Just make a note that you check your email from FOGSI and look into all the details. So I think Achal, I can see. Welcome Achal, and welcome all the speakers, chairpersons, as well as the moderators and panelists. And thank you Ritu and Kanti for being there as coordinators today.
Thank you so much, madam, for your pearls of blessings. And you're really a source of inspiration to all of us. Thank you for being here, madam. And now I would move on to the summary of day 2 and overview of the day 3 topics. Yesterday, we had an in-depth discussion on the evaluation and the proposed treatment protocols for male infertility and IUI, and also case-based scenarios, especially focusing on paternal aging and discussing various clinical aspects. Today, we move to IVF, ICSI, and advanced ART and have more insights into the selection of patients, early referrals, stimulation protocols, luteal phase defect supports, medico-legal aspects, and various case discussions, which will really be helpful in our clinical practice. So with this, I hand over to Dr. Kanti Bansal to start the scientific session. Before we move on, just instruction to all the participants who are there about the post-test MCQs. Attendance for all 3 days course is compulsory. A Google link for MCQs will be sent in the chat box. Those who have attended all the 3 days courses and passed with 50% marks on each day, they only get the certificate from ICOG, and these certificates are going to reach you within a month's time. Please note that this online course is just an acknowledgement of attendance. Practice depends on your skill, your experience, which we do not certify. So we do not endorse any skills of attendees. The videos will be put on the ICOG website in due course of time. And for the course material and equipment details, you can communicate with the course coordinators. With this, I hand over to Dr. Kanti Bansal.
Yeah, thank you, Dr. Ritu. I have great pleasure to open this session 1 at this webinar, and this is one of the most important aspects of the IVF, ICSI, and advanced ART course, I think. And for that, we have our first speaker, Dr. Charmila Ayub. She's the director. Can I just see that, please? Of Aditi Hospital and Parvati Ayub Fertility Center, and she's a consultant also at the Southern Railway Hospital, Trichy, Vice President FOGSI 2024, Vice President Trichy OBGY Society, Secretary Justosis India Association, and also she's the governing council member of our ICOS. I would like to, So Professor J.B. Sharma, who doesn't know him, he is the head department of obstetrics and gynecology, Yashoda Medicity, Indirapuram, NCR, and former professor and unit head of Department of Obstetrics and Gynecology, AIIMS, New Delhi. Most important is he's been awarded the Dr. B.C. Roy Award by Honorable President of India in 2015 for research in obstetrics and gynecology. About 425 publications in indexed and non-indexed journals, with 225 in peer-reviewed. Author of many textbooks of obstetrics and gynecology, midwifery, and obstetrical nursing. And he's also the...
Kanti madam, introduction in 2 lines only is enough.
Yeah, okay. Next,
Everybody
Chaitanya.
known.
Yeah,
just 2 lines.
Yeah, Dr. Chaitanya Ganpule. He is chairperson of Endocrinology Committee, FOGSI 2024-26, and he is the director, Pearl Women Hospital and Yash IVF, Pune. Yes. Session 1 speakers, I think I have introduced all of them. So,
can we have Dr. Manila Kaushal introduce our first speaker, Dr. Anchal Garg, because the other 3 chairpersons are held up and they will be coming in a little bit.
Okay.
Thank you, Dr. Pratik, Dr. Ritu ma'am, Dr. Sarita ma'am, for allowing me to be a chairperson here. But without any delay, I would like to introduce our first speaker, Dr. Anchal Garg. She is director at Chief Fertility and IVF Consultant, also at Colors IVF and Fertility Center, Lucknow. She has established and headed IVF unit at Reputed Hospital over the decades, having fellowship training in infertility, masters in reproductive medicine from London, with so many awards and accolades to her. I would like to invite her to speak on patient selection and early referral to ART. Over to you, Dr. Anchal.
Thank you so much, ma'am. A very good evening to all respected seniors and your friends. At the outset, I want to thank Dr. Prateek sir for making me a part of this wonderful academic program. Thank you so much, sir. And thank you so much, Sheila ma'am, for having me here. And it's wonderful being a part of the ICOG program.
Welcome.
Thank you, ma'am. May I share the slides?
Yes, please go ahead. Host, you can share. Chaitanya is logging in. I'm just calling Dr. J.D. Sharma.
Dr. Anchal can start.
Can you please help me with the sharing? I can't see
Anchal,
that.
please help her for the screen share.
Madam, please open your presentation.
Yeah, I can see it.
Minimize it and click on share button on your screen.
Yeah.
Correct. Make it full screen. Thank you.
Is it visible?
Yeah, we are able to see. Yes, yes.
Thank you. So patient selection and early referral to ART is extremely important, and half the battle is won if the patient selection is right. But before we discuss why it is important, just an overview of infertility and spontaneous conception. Infertility, as we know, is a disease, and it is defined by the failure to achieve a clinical pregnancy after 12 months or more of regular unprotected intercourse. And the duration of failure to conceive should be above an year before an investigation is undertaken, unless medical history and physical findings dictate earlier evaluation and treatment. And in women aged above 35 years, this duration is reduced to 6 months. So this definition is based on epidemiological studies which have shown that 80% of the couples in the general population normally conceive by that stage, that is 1 year, and the monthly fecundity rate in general population is only 15 to 20%. So what are the odds? The probability of conception depends on the length of exposure, quarter frequency, and the age of the couple, and the number of months of trying. Various prediction models have shown the factor, the age factor, then the duration of infertility, and the type of female infertility, the cause of infertility, and the fertility problems in the male partner. So all these then formed a prediction model to predict the spontaneous conception. Also, the age factor is very important, and as we can see here, with age, the probability of conception goes on decreasing. So why is selection important? It is estimated that more than 15% of the couples living in developed countries are infertile. No major change in prevalence is there, but there has been an increase in demand for treatment during the past decade because of the perception that effective ART treatments are now easily available at affordable cost. Although ART was initially developed for patients with tubal infertility only, but currently it's used for almost all kinds of infertility problems because its success rates are expected to be higher than those of conventional treatments. But it also has its disadvantages like OHSS and multiple pregnancies, and also the cost. So infertility treatment should therefore be individualized to avoid subjecting couples to unnecessary risks due to overtreatment, and such as the unnecessary use of ART treatments, or to inappropriately delay because of undertreatment. As we can see, duration does affect the pregnancy rate. So it's very important to refer proper patient at proper time for ART. And time to pregnancy. Time is definitely important. time to a healthy singleton delivery is an important consideration when making treatment decision for ART. It should be included as an aspect of decision-making process for women of all ages. Special emphasis has to be given for women aged above 35 years, as discussed, as fertility declines with age, which is gradual from 30 to 35 years and accelerates thereafter. Increased aneuploidy rates in women aged more than 35 years further impacts fertility. So measuring success in infertility, IUI, ART, is not just based on the outcomes, but it also involves the cost and the time factor, which is very important. So time to live birth this encompasses the critical components of cost, time, and outcomes. It is patient-centric. It acknowledges all the clinical and social issues that are critical to managing fertility. So the various categories of infertile couples are those with single defect in one of the partners, then those with multiple defects in one or both the partners, and then those with no apparent defect, that is unexplained infertility. And this is the classification of infertile couples. These are the various causes of infertility which we are all familiar with. Now, the favorable group of infertile couples comprise those with anovulation, commonest is PCOS, then early endometriosis, unexplained infertility, mild anatomical defect, and mild oligozoospermia. This group will respond to medical or surgical treatments. Few will require IUI or ART, and IUI will be successful equally as ART. But the unfavorable group of infertile couples involves advanced endometriosis, uterine synechia, azoospermia, asthenospermia, tense pelvic adhesions. It is a difficult to treat group and active management is required. Now, conditions for which the patient should be referred for ART. Amongst the female factors, we have the tubal factors, where microsurgical techniques for tubal and peritoneal disease have failed or are unlikely to benefit the patient. Presence of dense peritubal adhesions, condition of the tubal wall, condition of the ciliary epithelium, and degree of embryal damage. Past history of tuberculosis, bilateral hydrosalpinx is there, already patient undergone tuboplasty, and those with inaccessible ovaries and history of ectopic pregnancy. Then we have the uterine factors, that is Mullerian agenesis or congenital uterine anomalies, women with severe intrauterine adhesions refractory to surgical lysis of the adhesions. Then we have ovarian factors like hypogonadotropic anovulation, oligoovulation, PCOS, low ovarian reserve. After 3 to 4 cycles of IUI, we can consider the cervical factors. Endometriosis. Now, women with moderate to severe endometriosis are there, those in whom medical or surgical therapy has failed, and sometimes in cases of mild to moderate endometriosis in the presence of other factors contributing to infertility. In such patients, we must proceed to IVF. So, if the age of the woman is less than 35 years with grade 1 and 2 endometriosis, then the first line of treatment would be ovulation induction and IUI. If the age of the woman is above 35 years, then aggressive management has to be done or IVF may be considered. In cases of patients with stage 3 and 4 endometriosis, conservative surgery with laparoscopy may be beneficial, but early decision for IVF and embryo transfer is best in stage 3 and 4. Coming to those with premature or timely menopause, here a use of donor oocytes and donor embryos may be needed. Women in the perimenopausal age group, those with genetic disorders, those undergone radiation therapy, and those where ovaries are not accessible by ultrasound due to severe adhesions. Obesity also has its implications. Female obesity impairs the reproductive outcome of ovum donation, probably as a result of reduced uterine receptivity. Coming to male factors, there can be various male factors like ejaculatory dysfunction, then hypospadias, neurological problems are there, retrograde ejaculation. So semen analysis is a test that has to be done, and it comprises a sperm concentration, motility, and morphology. And the WHO has given an apt definition of the normal as a sperm concentration of more than 16 million per ml, then a progressive motility of more than 30%. So this is the WHO 6th edition category of the various parameters of the semen analysis. So it also guides the management decisions and influences the choice of expectant management in cases of IUI, IVF, and FOGSI. So coming to this, if the total motile sperm count is 10 to 20 million, then the pregnancy rate per cycle is 18.29%. If it is 5 to 10 million, then it is 5.6%. If it is less than 5 million, it is 2.7%. So if the pre-wash total motile sperm count is more than 5 million, then the treatment of choice is IUI. If it is 1 to 5 million, it is IVF. And if it is less than 1 million, it is ICSI. So if the inseminating motile sperm count is more than 1 million, then we can do 3 to 4 cycles of IUI if the egg reserve of the female permits. But if the inseminating motile sperm count is less than 1 million and the morphology is more than 4%, then further IUI can be attempted. But if the morphology is less than 4%, then ICSI has to be done, because morphology also plays a very important role. Coming to the immunological factors, and when methods like immunosuppression and others have failed in the presence of anti-sperm antibodies, either in the male or the female partner, then we may have to do IVF for ICSI. In unexplained infertility, couples who have prolonged unexplained infertility could benefit from IVF. Many factors such as subtle ovulation defects, defects in ovum pickup, gamete transport, tubal environment, sperm abnormality, oocyte abnormality may come to light when IVF is used. So this is the efficacy of various treatments in unexplained infertility. If there is no treatment, then it is 1.3%, the combined pregnancy rate per cycle. And in case of IUI, it is 3.8%. Along with the use of oral ovulogens, it becomes 5.6%. With gonadotropins, it is 7.7%. With gonadotropins and IUI combined, it is 17.1%. With IVF, it is 20.7%. And this is the flow chart for unexplained infertility. NICE guidelines also said that for people with unexplained infertility, mild endometriosis, and mild male factor who are having regular unprotected intercourse, they advised them to try to conceive for 2 years before considering IVF. And then various papers have also shown and recommended. So here, this is the ESHRE recommendation that IUI with ovarian stimulation is recommended as a first-line treatment for couples with unexplained infertility. And IVF is probably not recommended over IUI with ovarian stimulation in couples with it. So these are the ART methods that we commonly use: the IUI, then IVF, ICSI, oocyte and embryo donation, cryopreservation, assisted hatching, and the various sperm retrieval procedures. So it should be emphasized that the choice of treatment is influenced by factors like the age of the woman and the duration of infertility. The age of the female partner is one of the most important factors determining spontaneous fertility. So sometimes nature just needs that little help. Therefore, we need such procedures. And the choice of the procedure also depends upon the needs, resources, circumstances of the couple, availability of the facilities, and the experience and expertise of the gynecologist and the embryologist. So the common indications for intrauterine insemination are here. The prerequisite is that at least one fallopian tube must be normal and patent. So the indications are: it can be done in mild male factor infertility, unexplained infertility, ovulatory dysfunction, PCOS, mild endometriosis, cervical factors, coital problems, and immunological factors, then the infections, and in cases of donor sperm. The indications for donor IUI would be severely subnormal semen parameters, where ICSI is not an option due to financial constraints of the patients, and the couple does not wish to undergo any of the sophisticated ART procedures. Then in cases of azoospermia, where patient is not ready for ICSI, in cases of obstructed azoospermia, and RH isoimmunization and hereditary disease in the male partners. Then there are various legal and ethical concerns for donor IUI, and that has to be taken into consideration. Cryopreserved samples also can be used in cases of insemination with husband's frozen sperm, in case of an absentee husband, then before anti-cancer treatment, before vasectomy, with poor semen parameters, with drug therapy, and in cases of donor insemination. So here again, various factors have been considered which influence the treatment outcomes, like the age, the infertility duration, the etiology of infertility, type of infertility, the sperm count, then the progressive motility, and other factors. So active management of infertility has to be taken into consideration at the appropriate time. Age factor, as discussed, is also very important, and IUI seems to be a poor treatment option for women over 40 years of age. Now, IUI in tubal block. In cases of bilateral, it is contraindicated, and one should proceed for IVF. But if it is unilateral, then we can do IUI. And the chances, the cumulative pregnancy rate after 3 cycles of IUI in unilateral tubal block is 26.3%. In cases of unexplained infertility, it is 44.7%. If there is proximal tubal block, it is 38.1%. And if it is distal tubal block, it is 11.7%. Also, IUI can be used in poor ovarian reserve, but with caution so that further decline in the egg reserve does not happen, and we should timely proceed to IVF. Then in unexplained infertility, IUI, like discussed, IUI with ovarian stimulation has been recommended as a first line. In endometriosis, in grade 1 and 2, we should proceed with IUI and ovarian stimulation, and with 3 and 4, we should proceed with IVF. These are the S3 guidelines. And immunological, we have already discussed in the serodiscordant. Natural IUI also can be done for those women who have normal ovulatory cycles. And contraindications for IUI, the absolute ones are tubal pathology and genital tract infection, stage 3 and 4 endometriosis, hyperstimulated ovaries. And then relative contraindications are genetic abnormality in the husband.
Anchal, we'll make it short little.
Yeah, sure, ma'am. So indications for IVF ET, irreversible tubal pathology, male factor, moderate to severe odds, unexplained infertility, endometriosis, and the various PGT tests. For ICSI, again, we have various indications with ejaculated spermatozoa and those with surgically extracted sperm. And these are the various indications for oocyte donation and the embryo donation, and then the PGT tests. So we see that IVF is more complex. There is a tedious stimulation and monitoring, more expensive, more stressful, and it can be used for any indication. But unrealistic expectations should not be there. And thus, before referring for ART, patient selection is very important on the basis of the evaluation. Evaluation of the couple has to be done as a unit. The various evaluation of the husband and the wife has to be there. So just to conclude, the main indications include tubal disease. For ART procedures include tubal disease, endometriosis, and the male factor and prolonged unexplained infertility. And aggressive ART treatments should be discouraged in women up in their late 40s, as the chances of success is often unrealistic except in oocyte donation programs. Thank you.
Dr. Kanti, madam.
Thank you, Dr. Anchal. It was a wonderful talk. You have in detail given the principle of reproductive medicine, the right patient, right time, and the right treatment. So my other co-chairperson, anybody would like
Dr.
to
J.B. Sharma sir is there.
Yeah. Hi, Dr. Ritu. Hi.
Hello, sir.
Hello. How are you, ma'am? Thank you. Yeah, it's a real pleasure to be here, and thanks to Pratik and Dr. Ritu for calling me here. So Dr. Anchal has done, I heard her lecture beautifully. She highlighted everything, especially how to select the patient and early referral to ART. And she beautifully highlighted all the indications of IUI, and at the same time, what are the absolute contraindications, what are other contraindications like bilateral tubal block. So I think everything, all the basically esteemed delegates will be highly benefited. She has made everything very clear, and we should have realistic expectation from IUI, as she has said. But I mean, IUI should be tried before going for IVF in suitable patients. So thank you very much for the nice lecture, Dr. Anchal.
Thank you, sir.
Kanti ma'am, we can invite Dr. Charmila. Charmila, madam.
Yeah.
To invite the next speaker, Dr. Pragya Mishra.
Sharmila ma'am, we have introduced you already in our absence. Thank you for joining us.
Oh, thank you, Pratik. It
Yeah,
was a
already
wonderful.
introduced to Sharmila.
Thank you, ma'am. It was a wonderful talk by Dr. Anchal, and there are some questions in the chat box. I think Pratik has answered, but you can answer them also. There are some questions on that. So the second talk is going to be by Dr. Pragya Mishra, and she's going to talk on the pre-cycle checklist and counseling. And that's a very, very important part of any IVF procedure, along with the lab checklist. This is also very, very important. And it's my honor to introduce Dr. Pragya Mishra Chowdhury. She's a consultant infertility specialist at New Test Tube Baby Center and MGM Hospital Research Center Private Limited Patna, and she's been awarded so many awards. And she's also has been one of the executives from Patna, who's come in a big way in the national side also. And she's contributed several chapters in FOGSI publications, and she's been the organizing secretary of various conferences. Can I request Dr. Pragya to start a talk?
Thank you so much, Dr. Charmila, for the kind introduction. I think I'll start sharing my screen.
Dr. Pragya is one of our past GCLs. We've had the pleasure of working together on several projects. Recently, I was in Patna, and she's a fabulous host.
Thank you, Dr. Pratik, and thank you, team ICOG, and especially Dr. Sheila Mane and Dr. Pratik Tambe for the opportunity. I think it's Dr. Pratik Tambe is something he has to be admired when it comes to inclusiveness. You know, he just tries to include everybody, you know, at some point or the other, at whatever positions he's held, you know, in FOGSI, outside FOGSI. Thank you so much for the opportunity. I think you can see my screen. Yeah. So I have been asked to give a talk on a very simple topic, yet very important, because without this, I think everything goes wrong. So it's something, you know, we just can't skip. So I'm audible and legible, fine?
Yeah.
Perfectly fine.
Perfect.
So, you know, we have to, well, the outline of my presentation includes, because it's very important to tell the patient what is IVF, and the talk lays the importance of pre-IVF counseling and the goals of pre-IVF counseling, which are informed consent, emotional preparation, setting realistic expectations, and the pre-IVF checklist. Now, we have to tell the patient, don't presume that she knows everything. You have to tell her that, well, your ovaries are going to be stimulated, then eggs are going to be retrieved, followed by fertilization in the incubators and embryo culture, embryo transfer, and luteal phase support. Or you can show this very nice pyramidal diagram where you can see visible, you can tell your patients, well, you have some visible small follicles prior to stimulation. At the end of stimulation, you will see large follicles. Then we are going to retrieve the eggs, then mature eggs. Then we have to fertilize these eggs, take them up to day 3 or to the blastocyst stage. And we have to, well, wherever available and indicated, we have to go for genetically normal embryos, ending up in, as far as possible, clinical pregnancies. So, you know, we have to prepare the patients for the IVF journey. And before delving into the nitty-gritty of preparation for IVF implantation, it's essential to grasp the fundamental aspects of the IVF process, which involves fertilizing an egg with sperm outside the body, and the resulting embryo is then implanted in the uterus. While this may sound straightforward, the journey encompasses several stages, each demanding careful consideration. Now, females play a pivotal role in the IVF process, and IVF preparation for females is integral to its success. So, lifestyle modifications, including maintaining a healthy weight, adopting a balanced diet, and incorporating regular exercise, can significantly enhance fertility. And understanding the hormonal changes associated with IVF and managing stress through relaxation techniques are crucial aspects of female IVF preparation. Now, while females bear the physical burden of the IVF process, IVF preparation for males also plays a vital role in ensuring its success. And of course, you just heard a wonderful talk by Dr. Aanchal Garg. Male fertility can be influenced by factors such as diet, exercise, and lifestyle choices, and incorporating foods rich in antioxidants, maintaining a healthy weight, and avoiding excessive heat exposure to the genital area are essential considerations for male IVF preparation. Now, coming to the checklist, we need to review the medical history of both partners. Do not forget that. Conduct a thorough physical examination. Ensure that any underlying medical conditions such as diabetes, hypertension, or thyroid disorders are well managed. Then assess the general health and fertility history of both the partners, previous treatments if they have received any, previous investigations, and partners' medical and reproductive history. Now, assessing the ovarian reserve through tests like AMH, FSH, ultrasound for antral follicle count, infectious disease screening like for HIV, hepatitis B, C, check for male infertility issues through semen analysis, and other relevant tests like DNA fragmentation tests. Now, offer psychological evaluation. Well, it's something which cannot be overemphasized. Offer counseling or refer patients to a counselor to assess their emotional readiness for IVF FIXI, because she may not be prepared at present for IVF, and you may just write her up for IVF. Address any concerns or anxieties they may have about the procedure. Then emotional and psychological support includes handling stress, anxiety, and how to cope and coping strategies. Then counseling support services, importance of partner and family support. Lifestyle modification, like advise the patients to adopt a healthy lifestyle, including maintaining a balanced diet, regular exercise, and avoiding smoking and excessive alcohol consumption. Then practical sessions are given importance and need to tell them that it's time to change your body. Discuss the importance of a healthy BMI for both partners. Then list of supplements recommended to be taken at least 6 months prior to conception. They are like folic acid, iron, calcium, vitamin D, E, vitamin B6, B12, zinc, omega-3, iodine, and of course in women with poor ovarian reserve like DHEA and coenzyme Q10. Now, assess the medications both partners are currently taking and make necessary adjustments to those that may interfere with fertility or pregnancy. It's very, very important. Then check the immunization status. Ensure that both partners are up to date on immunizations, especially rubella and varicella, to prevent potential risks during pregnancy, because you may have worked really hard to give them the success rate in IVF, and there can be problems because of these infections. Now, infection screening, screen for sexually transmitted infections and other infections that might affect fertility or pregnancy. Then genetic testing, consider genetic testing for both partners to identify potential hereditary conditions that could be passed on to the offspring. Then screening is must in cases of male infertility with azoospermia, severe oligospermia. Then lifestyle factors, discuss the impact of stress and ways to manage it, such as relaxation techniques or stress reduction strategies. Encourage both partners to avoid exposure to environmental toxins and chemicals that may negatively affect fertility. Now, financial consultation and planning, I think that is very, very important, especially, we are not in a country where the government is funding for IVF. It's mostly done in the private sectors. So do provide a detailed breakdown of the costs associated with IVF FIXI, cost of IVF and the medications, then package options if available, or insurance coverage if applicable, and planning for multiple cycles. Then consent form, ensure the patients understand and sign consent forms for IVF FIXI, including the risks and potential outcomes. Then sperm preparation, if needed, discuss the process of sperm retrieval with the male partner, whether through ejaculation, testicular sperm extraction, or other methods. Now, ovarian stimulation, well, we do need to explain the process of ovarian stimulation in detail, the medications involved, and the associated monitoring, including ultrasounds and hormone level checks. You do need to tell the patient, the number of times that she may have to come for ultrasound, because sometimes, traveling from long distances becomes a problem for the patient. Now, embryo transfer, discuss the embryo transfer process, including the number of embryos to transfer and any specific preferences the patients may have. Now, encourage the support network is also very important. So encourage patients to establish a support network of family and friends who can provide emotional assistance during the IVF ICSI process. Then follow-up appointments, schedule follow-up appointments to monitor the progress of the treatment and adjust the plan as needed. Now, ethical and legal considerations. Now, you have to mention about, well, you have to give them informed consent and need to document whatever you have spoken to them or explained to them. We have to tell them about embryo freezing and third-party reproduction if needed, need for donor sperms, eggs, or surrogacy. Because sometimes, patients, we just presume that the patient knows everything, whereas the patient has no clue to what's actually happening. So it's all very, very important. Now, discuss legal and ethical issues, including the disposition of unused embryos and any related agreements. Now, the success rates and prognosis factors affecting success, age, ovarian reserve, cause of infertility, they all are important. They are all involved in ascribing a success rate to your treatment. So you do need to explain all this to your patients and give them individualized success estimation, the number of cycles typically required. Then there are common myths and misconceptions, and that really, we have to alleviate those, because to clarify the false beliefs about IVF success. Some women, they think that IVF means that, she's going to have a male baby, especially in our country scenario, which really is so, I think, it just cannot be changed sometimes. So you have to tell them that it's not, IVF is not for a male or a female. You cannot choose that. Those things, we really have to explain to them. Then if there can be any post-procedural risks such as pain or any complications related to IVF, then importance of evidence-based expectations. You really need to tell them that, well, in the Western world, the success rate is this much overall in the country, and my success rate, my clinic gives a success rate of this. So, all these things have to be. So I think the first one or two consultations are very, very important, because it includes the counseling as well as the IVF, pre-IVF checklist. Now, Q&As, well, don't discourage questions from the patients, encourage open communications, address the couple's doubts and concerns. So only then, we can be empathetic fertility specialists. Then counseling and support are the key. It's important to tailor this checklist to the specific needs and circumstances of each patient, as infertility cases can vary significantly. Then clear communication, counseling, and support are essential through the IVF ICSI journey to help patients make informed decisions and achieve the best possible outcomes. So some take-home messages, or rather I would say take-to-clinic messages. Well, at least 6 months before conception, look into the following: lifestyle correction, like alcohol, smoking, sleep deprivation, weight check. So we need to tell the patient, get your exercise and diet in order. Then the supplements like folic acid and calcium, preconception physical examination, then the genetic risk assessment wherever indicated, find out if the baby will be at high risk for certain diseases. Then medication, you need to tell the patient that check with your doctor if you are undergoing treatment, and which has to be stopped prior to embarking upon the IVF journey. Then the blood tests ensure thyroid levels, vitamin D, and blood sugar, which are have to be within the range. Then review the key points with the patients, then set a roadmap for IVF preparation, and give them a contact information for further counseling. It shouldn't be that you have just explained, or from your side, whatever you have told the patient. And, if she has any doubts, even she has the right to have some in contact numbers, so that she can clarify her doubts, or if she needs any further counseling regarding the whole IVF process. So thank you so much for a very patient listening. It has brought me to the end of my presentation. I would still say that it was a very, very simple topic which had been given to me, but I think it's very, very important because without that, nothing can go right. If you have forgotten what you have to do to the patients or treat the illnesses prior and encourage them to lose weight or set up good personal habits, if these little things, nitty gritty of IVF, we just cannot overlook. Thank you once again, ICOG and Dr. Sheila Mane and Dr. Pratik Tambe especially, and the whole team and the conveners who have taken so much, made so much efforts, Dr. Kanti Bansal, Dr. Ritu Khanna. Yes. And I can see my friends everywhere.
Hi, Pragya. Really excellent talk, Pragya. Always, you speak so well from your personal experience also. I have seen Pragya working in our hospital very well, and you have beautifully highlighted. I like the idea of your proper counseling of the patient, proper checklist is absolutely mandatory. Now, just like in each operation, we are doing checklist. So same way in IVF and ART also it is needed. And then the ethical issues, I like your that slide that, ethical issues are extremely important in this. So thank you very much. It was beautiful, nicely covered, and very easy to understand and learn. Thank you.
Thank you.
It was an excellent talk, Dr. Pragya.
Thank you, Chaitanya, for joining us. Please drive safe.
Thank you. Yeah, Pratik.
So for the introduction of the third speaker.
Yes.
I think all are reaching home or going to clinic.
Yes, madam. Yes.
Dr. Chaitanya, you'll introduce Dr. Shweta?
Sure. So we are in the third talk of our first session, and Dr. Shweta, she's going to speak on the importance of add-ons while the patient is going for ART. She's a director at Niramay Care Women's Center in Indore, and she's the chairperson of the Modern Technology in OBGYN Committee, FOGSI. She has been the Vice President, Indore Obstetrics and Gynecological Society, Managing Committee of ISAR, Joint Librarian for MP ISAR, and she has quite a lot of awards and accolades to her credit. So without much ado, I would like her to start with a talk on the add-ons before ART. Over to you,
Shweta will come back another time and she is going to tell us everything about AI in reproductive medicine. But today her talk is much more simpler.
Okay, so thank you, sir. Is my presentation shared?
Not yet.
Okay. One second.
Sorry if I distracted you.
No. Now this modern technology has become a pressure for me.
Modern technology chairperson only cannot deal with technology.
That's what has become a pressure on me now.
Sixer marte ho, Pratik.
I didn't say anything. It was just the sequence of events.
And I've shared the screen and I have.
No, it is Murphy's law. Whatever can go wrong will go wrong.
It says double click.
Pratik, it appears as if you are sitting in a space shuttle.
The same background since 6 years. I haven't changed it.
So what should the chairperson should have? Yeah, good evening. बाप रे, आपका CV देख के तो ऐसा लगता है कि बाप रे, what real research oriented person.
So what do I do now? Nilima is there?
Yeah,
Somebody has to help her.
Or you can share your slides with the host team and then they can play.
See, now you can
see. It's starting.
Yeah.
Shweta,
You can see.
Perfect.
Make it slideshow.
It's there.
It's
there.
First of all, I would like to thank Dr. Sheila Mane ma'am, Dr. Pratik Tambe sir for giving me this opportunity. Sorry for the glitches. I'll go really fast and swift. I want to take a moment to thank Dr. Sarita Bhalerao, Dr. Ritu Khanna ma'am, and especially thank Dr. Kanti Bansal ma'am, so kind of her to call and remind. And I'm so thrilled to be in the session with all the stalwarts and yet another set of stalwarts chairing me, Charmila ma'am, Sharma sir, Kanpole sir, and Manila ma'am. So now I'm
You're
going to
also a
talk about.
stalwart, Sweta. You are a stalwart yourself.
I just proved a minute back. So now the adjuvants in ART, I'm going to speak. So why do we need to speak on this? Because first of all, we'll go with what is the classification, what are the common adjuvants used, and likelihood of success of adjuvants, and then we'll conclude. So we know we all are in this infertility practice, and desperate, circumstances they lead to desperate measures. And when the patient comes and there is a failure, they always ask, "What happened? Did I go to my mica? Did I move? Did I do anything wrong?" So mostly they will take on themselves, and then again we'll tell that we had already counseled you, this will be the success, and but the acceptance is very low, so that counseling part needs to be done. But at the same time, all of us are desperately trying ki we should get some adjuvant to increase the egg quality, sperm quality, embryo quality, endometrium, and the work is going on all the adjuvants. But at the same time, we should very responsibly know the evidence of support or not supporting these adjuvants, so that we can counsel the patient that this is available and this is the success rate. Now it is up to you to whether to go for it or not, because if we don't offer, then they think we are not doing anything. But if we offer knowing that it is not going to benefit, but even the patient should know that this is an attempt and a genuine attempt, and then it is up to them whether to go for that adjunct or not. So infertility affects 15% of couples globally, and in India 10 to 15% of couples are infertile. But I think so these all factors are now going to increase, because we know that people are delaying their conception age, and they're going for career, and so many reasons are there. We know the male fertility is also dwindling, so we are well aware of the fact that this percentage has increased, and male factor is now almost 50% of the infertility. So why there is the need of add-ons, I've already conveyed. What are the add-ons? They are the adjuvant therapy, means the agents, tools, or procedures that can be implemented alongside the core ART, like ICSI or IVF, with the aim of improving fertility outcomes. So according to HFEA, the most recent National Fertility Patient Survey, 3/4 of patients who had fertility treatment in the last 2 years had at least one type of treatment add-on. So just imagine how many people are taking these add-ons. And however, most of the data supporting these adjuvants are based on anecdotal, heterogeneous, and underpowered studies, leading to debatable interpretation. So this is the thing which is published by our own Dr. Sohani Verma in Fertility Science Research in 2020. So I thought I'll present the study. Now, what are the common adjuvants used? If we look for the ovarian reserve, DHEA, we all use testosterone, growth hormone, metformin, antioxidant, and artificial oocyte activation. Adjuvants for sperm, like sperm DNA fragmentation test and antioxidant, and advanced sperm selection techniques like IMSI and FOGSI. Then for the endometrium, we use estrogen, heparin, aspirin, vasodilators, nitroglycerin, sildenafil, arginine, uterine relaxants, etosaban, endometrial scratching, endometrial injury, and reproductive immunology testing and potential therapies like steroid, IV immunoglobulin, anti-tumor necrosis factor alpha agents, intralipids, GCSF, autologous PRP, intrauterine HCG, and autologous peripheral blood mononuclear cells. So these all adjuvants we are using at one stage or other. It's not like all of them are using, but we can't deny that out of pressure by the patient or circumstances, we have offered and we do use with after proper counseling. So are they useful? That is the bottom line. Adjuvants for embryos like time-lapse imaging, embryo glue, assisted hatching, elective freeze-all, pre-implantation genetic screening, for aneuploidy, and autologous endometrial co-culture, and alternative therapies also like acupuncture and yoga. Now, some centers are offering alternative therapies as well. So we will be discussing some few common add-ons like screening hysteroscopy. So for hysteroscopy also, they have said that cervical dilatation, endometrial injury during the procedure are the mechanism by which hysteroscopy may improve IVF outcome. But they say the complication include the uterine perforation, infection, and a vasovagal attack and bleeding. And they say that a recent Cochrane review evaluating the role of screening hysteroscopy before IVF found a statistically significant high live birth if done before IVF, but the quality of evidence is low. And earlier reviews, they had shown an improved live birth after hysteroscopy compared with no intervention. So this, and in women with 2 or more IVF failures. So for women with a history of IVF failure also, they are then telling that screening hysteroscopy is useful. But in our practice, mostly, we go for hysteroscopy because it is a very minor procedure as far as India is concerned. If a patient fails IVF, if they are not at all willing or there are some circumstances, then we may offer 3D ultrasound. But if the patient is not very affording, or they cannot have multiple cycles, or there is more than male factor, then definitely a hysteroscopy is something which we recommend. So the bottom line, overall high quality evidence shows no benefit to performing routine hysteroscopy in women undergoing IVF, be it all women or those with 2 or more failures. So this is the conclusion which this paper has given us. Though practically in our practice, we do go for hysteroscopy before IVF, but then it is a controversial part which I have already conveyed. It may benefit a select group of women who have had 1 or more unsuccessful IVF attempt. Now, this is the evidence, but when you have a patient in front of you, you have to take into consideration many things. In practice, you can't be like, okay, I have read that 2 or more unsuccessful attempts, then I will do hysteroscopy. If a patient has only 2 embryos or 3 embryos and her first attempt is going to be her last attempt, then definitely doing a small procedure hysteroscopy. So we have to, tailor protocol according to the patient and individualize the treatment based on our theory, practical, and evidence-based medicine. So we have to put in everything together. Now, this endometrial receptivity test, a large prospective observational study, has shown that it could not demonstrate a better outcome after endometrial receptivity analysis and personalized embryo transfer. So, this is something which we do not advocate because, in our experience, we did not find it useful. Plus, the evidence also does not support it. Plus, it is a costly test. So, that is our take on this, and this is what the evidence says. Then, pre implantation genetic testing. So PGTA, PGTA was initially proposed for patients of advanced maternal age since they are at highest risk of producing embryos with uh, meiotic abnormalities. But several other patient categories like recurrent implantation failure, male infertility, and RPL are also now targeted. The current evidence for PGTA using current methodology for genetic analysis indicate limited improvement in live birth rate. So basically, PGTA is not going to increase your live birth rate. That is what is the evidence on PGTA. It can just decrease your time to pregnancy. It can tell that this embryo is normal, this is mosaic, or this is normal, abnormal, but it won't help you to increase the live birth rate. Assisted hatching is usually performed on day 3, 5, or 6 of the embryo development using non-contact laser, but mechanical or acidic solution have. Can you please decrease the volume? Can you please decrease the volume? Yeah. So assisted hatching is usually performed on day 3, 5, or 6 of embryo development using non-contact laser, but mechanical or acidic solution have also been used. So clinical use of assisted hatching for patients of advanced maternal age, smokers, and patients with raised FSH or when transferring embryos that have been cryopreserved has been used. But again, it has not shown to be beneficial in unselected or good prognosis patients. So no advantage was observed. Time-lapse imaging with or without embryo selection software. Now you are putting a new IVF lab and you think that if you get the time-lapse and you get the embryo selection software, your pregnancy rates will increase. But it has been proposed that time-lapse imaging has two advantages, both of which may be potentially improve birth rate. That is, it gives an embryo more stable environment as it limits the exposure to change in temperature, pH, and osmolarity. But such the timing of cell division intervals between the cell cycle may improve embryo selection, presumed to improve live birth rate and time to pregnancy. But finally, this has also not shown conclusively to improve the live birth rate or time to pregnancy. So this helps in embryo selection, but it is not, converting into the higher implantation or higher live birth rate. Artificial oocyte activation, it is actually associated with high degeneration rate. So where do we do it? We do it if there is a history of fertilization failure or globozoospermia. These are the only indications that require ino-4 based artificial oocyte activation to achieve fertilization. So with sperm with globozoospermia, this with inomycin resulted in higher amplitude of intracellular calcium rise during ICSI compared with calcimycin, and therefore could be the first line option even if the fertilization rate was not significantly different between compounds. Now, androgen DHEAs also we have all been using, but the evidence does not support that increases the live birth rate. It may increase your adrenal follicle count and the cell numbers, but it has not resulted in an increased live birth rate. Heparin, low molecular weight heparin also, Cochrane evaluated the effect on pregnancy outcome in women undergoing IVF without thrombophilia, and they found no statistically significant difference in live birth rate. Antioxidants also including vitamins, minerals, and polyunsaturated fatty acids, which have been used singly or in combined therapy, and N-acetylcysteine, melatonin, vitamin A, C, E, folic acid, myonistal, zinc, and selenium. But to summarize, the evidence does not support routine use of supplemental antioxidant for women undergoing IVF. So in our practice, mainly we are using folic acid. Seminal plasma also, a Cochrane review evaluated the effect of seminal plasma that was an improvement in clinical pregnancy rate noted with seminal plasma, but the analysis was restricted to studies at low risk of bias, and this difference was no longer present. And PRP also, there are no published RCTs examining the role of PRP in improving ovarian response. The literature on this subject appears limited to case series of poor responders. So again, this is, many people have worked on PRP and stem cells, but still we are inconclusive to say that they will improve either the ovarian reserve or the results of ovarian stimulation or even at the endometrial level. So everything is still in the experimental stage. Same funda mein, a nitroglycerin is a nitric oxide donor, which has been investigation in RCT, which assesses efficacy in inducing uterine dilatation and endometrial receptivity. But the RCT did not find improvement in implantation rate. And IVIG also, it has shown increased number of peripheral NK cells and abnormal T helper TH1, TH2 ratio, positive anti-thyroid antibody, anti-phospholipid antibody test, or increased TNF alpha levels and HLA antigen. So in all these immunological cases we have used, but there is no convincing evidence for the use and safety of IVIG as adjunct in women with recurrent implantation failure embarking on IVF. I think so it is a very important point because there are centers which are giving these therapies, and if it is an invasive therapy and if the patient has some side effect, maybe if they have some reaction or some serious side effect, then if this evidence doesn't support, then we might be in problems. So at least for these therapies, one should be very mindful. So this is the take clinic points. Screening hysteroscopy, they say low evidence, and DHEA moderate, testosterone moderate, growth hormone very low or not available, aspirin moderate, heparin moderate, antioxidant for female, also they say low evidence, antioxidant for male, they say no low evidence, seminal plasma low, PRP not available, embryo glue and adherence compound, they say published evidence may be suggestive of beneficial effect, but further RCTs are needed regarding elective single embryo transfer and management of multiple pregnancy, sperm DNA fragmentation, limited evidence, flushing of uterus, very low, endometrial scratching, low, addition of transfer media, moderate, dual stem, no data, stem cell mobilization, no data, steroid, no data, elective freeze or low evidence, time lapse, limited evidence, PGTA, limited evidence, mitochondrial DNA, load measurement, no evidence, assisted hatching, no evidence. So to conclude, in the absence of any convincing evidence, any adjuvant therapy should be offered only after fully informed consent of the patient based on up-to-date scientific information, and only if there is potential for cost-effective physiological and psychological benefit and minimum risk of harm. So clinicians should be fully aware of the best available current evidence, and patient must be informed about the experimental nature of any adjuvant therapy being offered to them, and there is no robust evidence of its safety or effectiveness. Further research in the form of good quality, preferably RCTs on a large number of patients is required to establish true effectiveness and safety of various adjuvant therapies. I hope it was useful and the clear message has gone across. Thank you for the opportunity once again. Thank you.
Shweta, I think you left out vitamin D.
Oh, yeah.
Because vitamin D is for calcium metabolism, and we know it works at the oocyte level also. And recently we had actually a meeting with the Osteoporosis Society of India, and I'm the vice president for that. So when the discussion happened, the Endocrine Society of India 2024 has said very clearly, you can give vitamin D to all your pregnant patients irrespective of their vitamin D levels, because we have a melanin content which does not allow vitamin D absorption, and most of the Indians are all vitamin D deficient according to massive studies done by the endocrinology group. So in that, when we correlate to this, I think in ART, it is worthwhile giving patients vitamin D before they go for ART cycles, because we are going to bring out the GCPR on the use of vitamin D in reproductive health also with them. That will work.
Yeah, Dr. Shweta.
Thank you very much
I
to
just
the
want
speakers and the chairperson. You're 10 minutes late, Dr. Kanti ma'am.
Okay.
Briefly. Go ahead,
So
briefly.
endometrial scratching, as you very correctly said, is not very much accepted. But then I recently heard that a proper endometrial scratching by one of the speakers, it does help. It's coming now, that literature is coming. Yeah.
Okay.
So my gratitude to our chairpersons, Dr. Charmila, Dr. J.B. Sharma, Dr. Chaitanya Ganpule, and Dr. Manila Kaushal for doing the honor. Three excellent talks, Dr. Anchal Gar, Dr. Pragya Mishra, and Dr. Shweta Kaur Jha, all evidence-based, setting the ball rolling very beautifully. Thank you, chairpersons, for your services. Let's move to the next session. We're already 10 minutes behind.
Yeah.
Thank you,
So I
Pratik.
think after the
Thank you,
fantastic.
Sheila madam, for the opportunity. Thank you, Dr. Ritu.
Thank you, Chaitanya.
Thank you.
Thank you.
Thank you.
And I think
Thank you, sir.
after those
Thank you.
fantastic presentations, we have all our patients selected, pre-cycle checklist all done, counseling and add-ons if any added. So we move to the next session with our stimulation, transfers, luteal phase support, and of course following the ART Act. For this, I invite my chairpersons. I would like to invite Dr. J.M. Kanan ma'am, Emeritus Professor Tamil Nadu MGR Medical University, Chennai. She has also been the Vice President FOGSI 2018, Partner in Maternity Child Health WHO since 2008, and has also won the Legend Award FOGSI 2025. Welcome to you, ma'am. Dr. Kanti Bansal, who is the Director, Safal Fertility Foundation, Ahmedabad. Pioneer in the field of assisted reproduction in India and Gujarat, produced the first IVF baby in Gujarat and Ahmedabad, 15 books published in PCOS, endometriosis, infertility, and ART, and lots of articles and chapters in the medical books. Welcome to you, ma'am. Dr. Shalini Kender, who is the Professor, Department of OBGYN, PGI Chandigarh, Secretary, Northern India Obstetric Gynec Society, and also a skilled laparoscopic surgeon, special interest in research and endometriosis and PCOS, having 3 ICMR projects for the same as investigator. Welcome to you, Dr. Shalini. Dr. Sonal Richarya is consultant, City Hospital and Research Center, Jabalpur. She is also the Vice President of Jabalpur Obstetric Gynec Society 2021, has won the DK Tank Trophy 2017 to 18, and lots of publications and achievements to her credit. Welcome to you, Dr. Sonal Richarya. So now I would request our chairpersons, Dr. Kanti Bansal ma'am, to introduce our first speaker, Dr. Jyoti Malik.
Dr. Jyoti Malik, we all know her. The special awards and achievements, she was awarded the APJ Abdul Kalam Appreciation Award, Delhi in 2020, and she has many other awards also. She is the medical superintendent of Institute of Medical Sciences, Bahadurgarh, and director, Roots IVF and Fertility Institute, JJIMS. Dr. Jyoti,
Yeah,
I
thank you
request
so
you
much.
to.
Thank you, Dr. Kanti. And I would, in the meantime, I'll share the screen.
So Jyoti has just finished her tenure as chairperson of Haryana ISAR. She very recently had an excellent annual conference. Thank you very much for inviting me there, and congratulations for your tenure.
Thank you so much. Thank you, Dr. Pratik, the convener, Dr. Sarita Bhalerao, and the coordinators, Dr. Ritu Khanna and Dr. Kanti. So today we are on the day 3 of this IVF FOGSI advanced ART being discussed today. And I have been allotted this topic. stimulation protocols in IVF. Now, I would be talking everything from these ESHRE guidelines, the Ovarian Stimulation Update 2025. Before we start, we should know that we have various types of gonadotrophins, urinary FSH, HMG. HMG has the FSH and LH activity. We have REC FSH, REC LH. REC LH basically is more for hypogonadotrophic hypogonadism and poor responders. Then we have the combined REC FSH and REC LH, the pergoveris, and the long-acting FSH with HCG preparation. So just an overview of the gonadotrophins, the types that we have. Then the GnRH analogs. So what are they? We have two types, agonists and antagonists. Agonist will cause initial stimulation followed by suppression. Antagonist will cause competitive blockade. And these we are using to prevent the premature LH surge. So how agonists are acting? They are causing an initial flare effect within the first 2-3 days by binding to the pituitary receptors. And in this time, they're increasing the FSH and LH. And after 7 to 10 days, when there is complete receptor desensitization, there is downregulation, there is pituitary suppression, and hence the FSH and LH secretion is decreased. The antagonist, what they do, they bind to the pituitary receptors directly, and therefore they cause an immediate suppression. So there is no flare effect here. There is a rapid reversible suppression. So these are the various ways we come on to the protocols now. So we are giving gonadotrophins, and here we are starting the GnRH antagonist. And here in the long and the agonist protocols, we have various types of protocols in the agonists. So we have the long agonist protocol, where we give analogs for 2 to 3 weeks, and downregulation of the pituitary is achieved, which we come to know by the E2 levels. But the disadvantage is it takes a longer time, a larger dose of analog is needed, and a larger number of gonadotrophins are needed. Then we have also ultra long, but that is not used, and it is more for the severe endometriosis cases. Short or the flare-up protocol means we start the analogs or the agonists on day 1 or 2 of the cycle. And then the exogenous FSH is started from day 3. So this reduces our time of stimulating, reduces the GnRH used, and reduces the gonadotrophins used, whether we use FSH or HMG, whatever we are using, those ampules, the number, the dosage, the duration decreases. The ultra short protocol we give for only 3 days, and this uses the flare-up technique. And then this protocol actually helps to retrieve more oocytes with a minimal risk of premature surge. So that was for the analogs. Now for the gonadotrophins, how we should be using, what are the different protocols? So in low dose protocol, we are using low dose of gonadotrophins, whatever it is. It could be HMG, it could be FSH, REC FSH, whatever you wish to use. Which one we should be using, what dose and all, we'll again discuss further. So in low dose, we scan and we may increase the dose by 100%, or if we are finding good follicles, then and the size is up to the mark, then we increase only by 50%. Chronic low dose protocol, what we do is that we increase the dose by 50% after 14 days. So for 14 days, we are giving a very low dose. We scan on day 14, and then we start increasing the dose by 50%. Again, scan after a week and increase the dose by either 50 or 100% depending on the follicular size. Step down, what we are doing, we are giving a higher dose in the beginning and then decreasing it after doing the scans on 7 or day 8, whatever. That could be a little variable according to what you choose. Now, here there will be a monofollicular development. It is more physiological. And the sequential, what is done is that initially we are increasing the dose, And once we see that the follicle is around 14, then we decrease the dose. So what is the principle there is that the FSH dependence of the leading follicle decreases as the follicle grows, and hence it is not needing that much of the gonadotrophins, and therefore one can decrease the dose by 50%. So if we are going with the sequential protocol. But all our protocols would be decided by whether it is a high responder, our patient is high responder, a normal responder, or a low responder. And high responder means we have a high AMH or a high AFC, and we have to be careful about hyperstimulation in these cases. Low responders means they have low ovarian reserve or they have a previous poor response. Now, now we start with the high responders first. So, is a delayed start stimulation whether it should be done? The ESHRE says there is no proven benefit in reducing hyperstimulation, and there are similar reproductive outcomes. The gonadotrophin dose comparisons, many studies have been done. They have compared the various doses of gonadotrophins, and they have seen that there are similar birth rates. Another study, they felt that with a higher dose, they are getting more oocytes, but there is also an increased risk of OHS. So basically, in high responders, we have to use a lower gonadotrophin dose because it maintains similar live birth rate and it reduces the risk of OHS. Now, so ESHRE, what exactly it recommends for high responders? A reduced dose, somewhere less than 150, an antagonist protocol, and avoid using excessive stimulation doses. Now, in normal responders, delayed start stimulation, again, there are comparable clinical pregnancy, ongoing pregnancy, and live birth rates. And some studies say that they showed fewer oocytes retrieved with the delayed start. So what does ESHRE say about delayed start in normal responders? They say it is not recommended. So the dose, how much should we be using the dose in these normal responders? So in a meta-analysis, it was seen that increasing the dose increases the oocyte number, but does not improve the live birth rate. And various comparisons were done between 100 versus 200, 150 to 225, 300. And all these, the key observation was that the higher dose did not improve the pregnancy outcomes in these normal responders. So final word is that something optimal is around 150. We should not routinely do a dose escalation or a dose reduction. A conventional can be something between 150 to 225 because our goal is to have an adequate oocyte yield, a good cumulative live birth rate, with a minimized OHSS. Now, in low responders, in a delayed start, they said that it is not recommended. Dr. Pratik, my electricity has gone, but I think I'm audible or not?
You're audible and visible. Please go ahead.
Right. Okay.
Yes.
Yeah, now it has come. The gen set must have started now. So sorry for that. Now, the ESHRE says, what about modified natural cycle? It is not routinely recommended, but it may be considered individually in very low ovarian reserves or if we are expecting a minimal response. So the various studies have been done about the modified natural cycle. Now the dose, very important. In low responders, should we give a higher dose? So they said slightly it increases the oocyte yield, but does not improve the live birth rate. So when compared a dose of around 450 versus 150, they saw that there were a little more oocytes retrieved, but with no increased advantage. And therefore, there is no additional benefit if we are using more than 300. So we be very, very clear about this part that even in low responders, a conventional dose should be somewhere between 150 to 225 and nothing more than 300 is recommended. because more gonadotrophin do not necessarily improve the live birth outcomes. So exactly what is the message for high responder? A ANTAG protocol, lower gonadotrophins, and a focus on prevention of OHS. Normal responders, a conventional stimulation, a optimal dose of 150. Low responders, avoid excessive doses, individualized treatment, and maybe we may consider it a modified natural cycle. So this is the same summary where in the responders, how much dose max we are going, and we need to avoid giving more in even in low responders and also in high responders so that we can prevent the OHS risk. Now, the suppression protocols. So there'll be various comparisons between whether we should be using agonist or vis-a-vis antagonist vis-a progestin protocols. That means progestin primed ovarian stimulation, or PPOS. So it was various studies. They have compared long versus short agonist protocol. And it was a RCT. There were 5 RCTs. It is a meta-analysis, and they found no significant difference whether we are using a long protocol or a short agonist protocol. Now, long versus ultra short also, there was no difference in the live birth and pregnancies. And it was from one RCT where there were 150 women were taken into this. Short versus ultra short, no significant difference in the pregnancy. Long protocol, when should we start it? Whether it should, the timing of the agonist start, whether it should be luteal phase start or it should be a follicular phase start. There were similar pregnancy and ongoing pregnancy rates. So both the approaches are acceptable. Long protocol, whether should we continue with this or we should give a stop GnRH agonist. So stopping at the start of stimulation, there is no difference between the pregnancy rates. So either strategy is okay. Agonist reduction during stimulation, again, reducing the dose, there is no significant benefit on any of the pregnancy or live birth rates. So dose reduction offers no proven advantage. So the ASHRAE recommendations is that though it is strongly recommending the long GnRH agonist protocol, and the short and ultra short is not being recommended. Now, why it is beneficial is because there is an excellent LH surge suppression, reduced cycle cancellation, more oocytes retrieved, and improved pregnancy outcomes. But it was it was considered a gold standard before we had the antagonist era. So these days we are in more of the antag or the antagonist era. And when they compare the antag with the long GnRH agonist, again, it was a meta-analysis with 36 RCTs, and there was comparable live birth and ongoing pregnancy rate. And there was a major advantage that there is a lower OHS risk with the antagonist. So that is worth remembering and understanding that it is very, very safe to use the ANTAG protocol. So the safety advantage is that there is significant reduction of the overall HS and the moderate and the severe OHSs. Now, ANTAG versus short agonist protocol. There is a key point that ANTAG protocol is at least equally effective and has a better safety profile when compared between the two. Flexible versus fixed. So flexible is associated with lower rate, and therefore a fixed is much better. So GnRH ANTAG is preferred over agonist, and their fixed is preferred over flexible. Fixed means we start the antagonist on day 6 or 7 rather than doing the ultrasound and seeing that the follicle is 14 mm, and then we start the antagonist. PPOS, and I think another 1 to 2 minutes. PPOS is we are giving the oral progestins, but the feature here is that it requires freeze-all strategy, and because the endometrium is not receptive here. So if we are using the PPOS, then we are freezing all. Now, the progestin versus the GnRH antagonist, there are various studies, and they have found that often there are a little more M2 oocytes with the progestins. That is what they found. Now, we use them in poor responders. We can use them in PMOS. I'm deliberately saying PMOS because these days our terminology is changing from PCOS to PMOS, or the PCOS from PCOS to PMOS. So these high responders, again, it is comparable live birth rates, but it is useful with the freeze-all approach. So the medroxyprogesterone and dydrogesterone can be used. So what is the message with the agonist? Long protocol is preferred. Short, ultra short is not superior. Antagonists have a comparable efficacy, a lower OHS. Progestins are an effective alternative, but they require a freeze-all strategy. So this is the summary. Long should be preferred. In long, it is the preferred one. Short, ultra short, not. Antag recommended. Fixed antag is preferred. And in progestin, one has to do a freeze-all. So the use of purified HP, FSH and HMG is equally recommended. Addition of letrozole is probably not recommended for low responders. Clomiphene is probably not recommended for predicted high responders. Clomiphene alone or in combination with gonadotrophins and gonadotrophin stimulation alone are probably equally recommended for predicted low responders. And REC FSH, LH equally recommended. REC FSH and purified FSH equally recommended with the GnRH agonist protocols. Combination alone are equally recommended for general IVF population as well as for low responders and for the advanced age. And the combined use of REC, FSH and HMG either from start or mid-phase is probably not recommended over the use of either REC FSH or HMG alone in normal and low responders. So that finishes, and definitely we need to give a proper luteal phase support, which in itself is we must have discussed that. So thank you so much. Thank you, Dr. Prateek, for giving me the opportunity, and thank you. There are, I think, 650 of us here, and I'm sure everybody should thank FOGSI and ICOG for giving us such a beautiful program. Thank you so much.
Thank you, Dr.
Jyoti, for the.
Go ahead.
I would request Dr. Jayam Khanna, madam, for her expert views.
I said long time, Jyoti.
Thanks for giving me this opportunity.
Thank you.
On this Guru Vachara day, I really feel humbled to be there in the ICOG, which I have started in 1990. And coming to this, your talk about this progesterone primed this thing, I think it is still India, we have a long way to go. And even in the West, randomized control studies are not yet available. As you said, ultra short and short are out of phase. And since antagonist is patient friendly, doctor friendly, and also staff friendly, and also research friendly, I think that is one which is going on. Of course, as you said, GnRH agonist protocol, I always insist on patients who had repeated failures. After 2 failures, I always ask, go for agonist protocol, so the long-acting protocol, so that we are changing for a better thing, for a better oocyte. Thank you, for Jyoti. All the best for you.
Thank you so much.
Thank you, Dr. Jayam, for your kind comments.
Yeah, thank you, Dr. Jayam, for joining. Thank you so much.
Yeah.
Thank you, ma'am, for being there.
12th year of my Baba, Pradishta Day.
Okay.
That is why I
Dr.
told
MC Patel sir has to leave because he has another event and he's requested to be allowed to speak earlier. I hope Venu and
Poonam accepts.
Options.
No problem, sir.
Objections.
Welcome.
No problem.
Thank you, Venu.
So I think I'll request Jayam madam to introduce Dr. MC Patel, sir.
Yeah. It's a pleasure to introduce my brother, MC Patel, whom I know from 2005. We were together in 2018 as Vice President.
Please share the CV, Neelima.
Yes.
Dr. MC Patel sir's CV.
Please
Yeah.
put MC
This
Patel.
is Venugopal CV.
Yeah.
Yeah.
Thank you.
And he has been my lovely friend as Vice President in 2018. And we have done wonderful academic as well as administrative work as expected in FOGSI. He has been the member of this Gujarat Society for a long, long time. And he is also the member of the PNDT Committee to Gujarat State. And he has been the president of the same Gujarat OBG1 Society. And he has organized very many conferences, and I have attended all those things. Presently, that is all not required. Now, what he wants to occupy the highest chair of FOGSI. And I am very sure my brother will be able to succeed in his goal with all the support of the 650 who have joined here. And please encourage him, as he's a very, very simple person, very, very easily reachable person. All the best to you, MC, for all your talks and all.
Thank you. Thank you, Jem. You are always with me to bless me in any of my activity. Thank you. Thank you for all the kind words. And let me share my screen. Is my screen seen?
Yes,
yes, sir.
Yes, sir. Please.
Yes. So, straightway. Greetings from Statue of Unity, tallest statue of world, and we all are proud of that statue. Warm welcome all the delegates and wishing you a litigation-free practice. At the outset, I would like to thank ICOG team and Dr. Sheila Mane and Dr. Pratik in particular for inviting me to share my views about the subject. But before I go to the subject, sorry, what happened? So it is my humble appeal to endorse my candidature for post of President FOGSI election year 2026, because my commitment is still there. Wherever you are, I'll be there. Promise to reach the unreached. So usually I start any of my talk with this question: is it worth discussing? Yes. If it is yes, then why? Because medical litigations are increasing in number constantly and steadily, and unluckily we gynecologists rank first. Whichever area we go, as far as litigation part is concerned, whether it is civil suit, whether it is criminal case application in medical council or in government or in human rights commission or so, and whichever the area we practice, obstetric, gynecology, sonography, ART or fetal medicine, any area, but we gynecologists are in driving seat as far as litigation numbers are concerned. And ignorance of law is no excuse, because as soon as any act, any law, any ordinance passes in government gazette, it is presumed by law that each and every citizen of India knows that law. So ignorance of law can never be an excuse. And as far as this ART Act is concerned, it was enacted in 25th January 2022, and same day Surrogacy Act also was enacted, and surrogacy rules were enacted on 11th of July 2022. Why this ART Act? What was the necessity of this act, and which are the objectives of this very act? To regulate ART services and to protect affected women and children from exploitation, to support oocyte donor by an insurance cover and protection from multiple embryo implantation, to provide rights to children born through ART equivalent to rights provided to biological children, to regulate cryopreservation, to make pre-implantation genetic testing mandatory, but with amendment now it is not mandatory, but it is for certain cases when there is a family history in sibling or in a spouse or in any member of a family, to ensure proper registration of ART clinics and bank, safe and ethical practice of ART, prevention of misuse, and ART research and development. So these were the objectives of this act particularly. but registration of center is very much must. No center can function without registration under ART Act, whether it could be ART clinic or ART bank or surrogacy clinic, whichever the area you are going to practice, but your center should be registered, either level 1 as far as ART clinic is concerned, if you are interested up to IUI only, and level 2 if you are interested more than IUI and all the procedure related to ART. As far as ART bank is concerned, it is responsible for screening, collection, and registration of semen donor and cryopreservation of sperm, perform screening and registration of oocyte donor, and then they will supply oocyte donor to ART clinic. Operates as a semen bank or oocyte bank or both, maintain records related to all the donors and update all this record with National Registry. As far as this registration is concerned, if it is granted, then it is for 5 years from date of registration, and certificate of registration is to be displayed at conspicuous place of business, and it is very much compulsory. Renewal of registration. So before your certificate is expired, you have to apply for a renewal of the registration 30 days prior, and application to appropriate authority in prescribed form with prescribed fees. And if registration is renewed, then again for more 5 years, center will be registered. And a very important part, no application for renewal shall be rejected without giving opportunity of being heard. So if at all renewal is rejected, then reason in writing will be given by appropriate authority, and you will be given chance to be heard, and you can solve that very query, and your center may be renewed. As far as eligibility is concerned, who can enter in ART program? So we will have ensure eligibility of commissioning couple or woman or donor in this ART program. So under section 21, to avail ART procedure, as far as women part is concerned, age limit is 21 to 50 years. For men, 21 to 55 years. Ovum donation, 23 to 35 years. Semen donation, 21 to 55 years. As far as surrogacy is concerned, as far as intending couple is concerned, men 26 to 55 and women 23 to 50 years. And as far as surrogate is concerned, 25 to 35 years of age. And as far as this age verification is concerned, you are under obligation to verify the age. So you can ask for any proof, ID proof, as far as age verification is concerned. One more eligibility criteria. These 4 tests are very much mandatory. Human immunodeficiency virus, that is HIV type 1 and 2, hepatitis B, hepatitis C, and VDRL. You can offer all other tests also, but these 4 tests are very much mandatory under section 21 of this act. As far as donor gametes from registered bank only, any ART clinic can avail services of donor gametes through registered ART bank only. Registered bank will supply donor gametes to registered ART clinic only. So ART bank is also under obligation to supply these services to registered ART clinic. In same way, ART clinic is under obligation to avail services from registered bank only. As far as this general duties of this clinic is concerned, they will issue a certificate to commissioning couple with discharge certificate of all the treatment going on with them, and if any ovum donor is supplied, or if it is a program of surrogate, surrogacy, then all the treatment going on with surrogate will also be communicated to commissioning couple. As far as counseling is concerned, it is a very vital part in ART practice, and we are under obligation to provide professional counseling with implications and chances of success related to that very procedure. We have to inform about advantages, disadvantages, cost of procedure, and their medical side effects, including possibility of multiple pregnancy and hyperstimulation should also be explained. So we are under obligation to help couple to achieve or arrive at informed decision about entering into ART program. Right of children, naturally child born through this ART treatment will enjoy all the rights as it is natural child, but due to natural wedlock. Donor shall relinquish all parental rights over the child or children which may be born from his or her gamete. So at the time of entering into this donor program, they will give a certificate that they are waiving their all the rights from child to be born with this program, and it is very compulsory. As far as confidentiality is concerned, we have to observe confidentiality of the patient and patients with us. But nowadays, now known donors are also allowed. So in this condition, we have to explain to the patient party and that donor too, not to disclose any information to anybody, because it is very much a must as far as confidentiality of couple is concerned. Grievance cell. So every clinic is under obligation to form grievance cell. So any aggrieved person or any visitor of that very clinic may complain to that member of grievance cell. So name of all the members of grievance cell should be displayed in waiting area, so one can avail services from them if at all they have any grievances against that very clinic or doctor or staff or whatever. As far as consent is concerned, written and informed consent of all the party involved in ART program is very much must, and at all possible stage, at the time of investigation, at the time of this stimulation, retrieval, then transfer, cryopreservation, if at all they are going go for that, then at every stage, written consent is very much must, and all these consent are given in prescribed form in ART Act. As far as these records are concerned, so under Form 14, 14A, 14B, and 15, record of use of donor gametes or oocyte donor or oocyte embryo records, and all these are to be maintained by ART Bank in a prescribed register. Withdrawal of consent. Patient has all the right to withdraw consent which is given prior before transfer. So before transfer, patient may withdraw, but we have to explain about consequences of withdrawal of consent. And if patient is not willing, then one cannot force. Patient is free to withdraw their consent, but consent, wherever it is taken, or agreement as far as surrogacy part is concerned, it should be in a local language. So language which patient could understand should be the language. As far as insurance is concerned, as far as donor part is concerned, then for 12 months and surrogate for 36 months with registered IRDA authority established insurance company, and affidavit by intending couple before honorable court that they have availed insurance services from registered company as far as surrogate party is concerned in surrogacy program. As far as records are concerned, to keep accurate records of all the donors, oocyte, sperm, embryo used or unused or stored. And when it is available online, now National Registry has started functioning. So we have to give all the information online, and within 1 month of information availed to us with that very patient or patient, that very program. Preservation of record for 10 years, and then after we have to transfer all the record to National Registry. But if at all there is any prosecution or any case, then till final disposal of that very case or 10 years, whichever is later, we have to preserve all those records. And as far as surrogacy part is concerned, we have to preserve record for 25 years. Here there is no provision after 25 years of that record to be transferred to National Registry. So after 25 years, one can destroy those records as per standard procedure of destroy of record. If there is early closure of clinic for any region, then all the records are to be transferred to National Registry in this particular situation. And as far as all this record which we are preserving, any appropriate authority is under obligation or is under, incurred with power to inspect all these record available with us. So any appropriate authority with designation, they may visit your clinic and they may ask for any record related to ART program. As far as provision of retrieval, transfer and supply and storage is concerned, there are some guidelines in ART Act. Not more than 3 oocytes or embryos may be placed in uterus in any treatment cycle. Women shall not be treated with gametes or embryos derived from more than one man or woman during that particular cycle. Clinic shall never mix semen from 2 individuals for procedures, especially under this act. Embryos shall not be split or used for twinning to increase the number of available embryos. Collection of gametes posthumously is available, but for that prior consent with commissioning couple is very much must. Clinic shall not use ovum derived from fetus. So there are guidelines about this. Screening of gamete donors, collection, screening and storage of semen and provision of oocyte donor, it is a duty of ART bank. So ART bank will screen all the donors and with all the required medical tests, etc. And bank shall not supply sperm or oocyte of a single donor to more than one commissioning couple at a time. But here there is no specification, never or for that day only. So again, this is gray area. As far as an oocyte donor shall donate oocyte only once in her lifetime. And here there is one more area as far as risk of OHS is concerned, because not more than 7 oocyte can be retrieved was the provision in this very act. But with pursue to the ART national body, and they have agreed that one can retrieve all the ovum, but they can use only 7 oocyte for this embryo formation and after embryo formation for transfer. All unused oocyte can be sent to a research purpose also, but with prior consent of commissioning couple. If commissioning couple has not given permission, that we cannot offer this ovum or any oocyte to research purposes. Bank shall obtain all necessary information in respect of sperm or oocyte donor, including name, Aadhaar number, or any information as far as identity is concerned. Because many a time, we all know that minor cannot enter into donation program. But many a time, even though she is minor, but looks like major and comes to clinic with fake Aadhaar card, and this type of problem happen, and it was happen in state of Tamil Nadu only, and 2 of our gynecologists faced very bad consequences as far as legal proceedings are concerned. Of course, we were medical legal counsel then after, and they were free of all the problems, but this type of problem may occur. So you should be very much vigilant at the time of selecting any donor, whether it is semen donor or it is ovum donor. As far as storage is concerned, we can store for 10 years, and then after we have to allow those to perish, or we can offer to research organization for research purposes, but with prior consent only. But here there is one provision. If at all we have to store for more than 10 years, many times, say for example, if it is a case of malignancy, and before treatment, if we have retrieved all this ovum and we have preserved, and it is needed to preserve more than 10 years, then with prior permission of National Registry and National Board, one can preserve even more than 10 years also. But prior permission is very much must. And there are some key points. Ensure that all unused gametes or embryos shall be preserved by ART clinic for use of the same recipient and shall not be used for any other couple. So any embryos or gametes preserved for that very couple will be used for that couple only. Allow cryopreservation of oocyte, sperm for onco-fertility, just I mentioned, for 10 years and even more than 10 years with national board's permission. Ensure control ovarian stimulation of women in order to prevent ovarian hyperstimulation. But we know even with control ovarian stimulation, patient may go in hyperstimulation. So at the time of counseling, we have to counsel patient for that also. As far as PGD is concerned,
I think
previously
we'll
it
have
was
to stop.
compulsory. Pardon?
We'll have to stop.
Okay. Only
Thank you,
1
sir.
minute. Okay,
Yes.
1 minute. So as far as this pre-existing genetic, PGT is concerned, so previously it was compulsory for all the patients, but with amendment, now if it is family history, then only we have to offer all these tests. It is not compulsory for all the patient. So when embryo suffers from pre-existing heritable, life-threatening or genetic disease, this embryo can be offered for research purposes to research institution, but of course with prior permission of couple. So all this is prohibited. No preconceptional sex selection, no prenatal sex determination, and nothing to promote probability of particular sex or identity of that very sex in this program. But there are exceptions to diagnose, to prevent, to treat sex-linked disorders or diseases. One can have sonography and one can have discussion with couple consent. So all this is prohibited. Cell transfer, use of gametes, zygotes, embryos, any part thereof, and information related to thereto, directly or indirectly to any party within or outside India. So it is very much prohibited and it is punishable offense, and there are provision of imprisonment of 5 to 10 years or fine of rupees 10 lakhs or 25 lakhs or both in certain condition. So to conclude, but as far as surrogacy part is concerned, time doesn't allow me. So I will stop here. Thank you. Thank you very much.
Thank you.
Thank you.
Thank you,
Thank you
Dr.
so
MC
much, sir.
Patel, sir. Apologies for cutting you short and wish you all the very best.
Thank you.
for
Thank you.
the election.
Thank you, sir, for that excellent deliberation and wishing you all the best, sir.
Thank
You so much for being with us. And now I request Dr. Shalini to please introduce the next speaker, Dr. Venugopal.
So Dr. Shalini is from PGI Chandigarh, and she was my co-convener for the ICOG reproductive medicine course a while ago when Dr. Parul Kotadawala was the chairperson a couple of years ago. I have sent you an unmute request, ma'am. You are still muted.
Thank
Nilima,
you,
can we
Dr.
hear the
Patel,
can we have
sir.
the slide share
Thank
for
you.
the CV? Nilima, please share the CV. Yeah, Shalini.
Yes, can you hear me now?
Yeah, we can hear you, ma'am.
Yeah, we can hear you.
Yeah. Yeah, I
Dr.
can't see the
Venugopal CV.
CV. Can I have the CV, please?
Yeah, here it is. Can you see it, Dr. Shalini?
No, I can't see.
So I'll go ahead and do the introduction.
Yeah.
Venu is a dear
Yes,
friend.
yes.
He was part of my endocrinology committee. We worked together since many years. He's one of the leading reproductive endocrinologists of Kerala, also practices in the Middle East. Currently, he is part of Ashwath's team. All the very best to you, Venu.
Okay.
And let's hear from you regarding day 3 and day 5 plans.
Thank you, Pratik. Is my presentation visible?
Not
No,
yet.
not yeah.
Not yet.
Okay, yeah,
It's
good.
It's come? Yeah.
yeah.
So good evening, respected chairpersons and dear colleagues. I want to start by just having a mention of thanks, Sheila madam, Sarita madam, Pratik. Dear Pratik is a very dear friend. Then Dr. Ritu and Kanti Bansal madam. Thank you very much for giving me a little bit of time to speak about a very important aspect in IVF. That is, I'm not going to go too much into the theory. I'll do a little bit of personal experience sharing, because how the developmental journey from day 3 to day 5 embryos, and I want to just confess that initially in my practice we used to always transfer day 3 embryos, but now we've evolved into selecting and individualizing. So that's the way the journey has been for me, and I'll just take you through the urge every IVF practitioner or clinician has to give an embryo which has the best prospect for implantation. So this is very important because nowadays it's so much competitive. We want to show a lot of pregnancy rates. I just take it through physiology. And if you see this, I think most of us are familiar with this physiology that after fertilization, when the embryo comes right into the cavity, it's not in a 3-stage, it comes here, it's in the early blastocyst stage, here it's in the morula stage. So that's where this whole debate starts, that, when physiologically this is what happens, then how come you end up transferring day 3 embryos, which are there into the uterus? So the thoughts that were given initially, the concepts that were there initially is, the first IVF pregnancy was a blastocyst transfer, because it was considered to be physiologically premature to expose early stage, that is day 2, day 3 embryos to the environment, especially after your superovulation. Then, all this, it was hypothesized that, if you have blastocyst stage embryos, it will permit the identification of embryos, better implantable embryos. So there was always a thought process in the favor of the blastocyst. The thing was that uterine fluid is stressful for a cleavage stage embryo. So all these things were there. But pendulum, gradually swung against it, against physiology. And as the time evolved, you would find that there are more and more transfers which are taking place as, day 2 embryos, day 3 embryos. And that persists even today, not everybody is going entirely for blastocyst transfer. And I'll just sort of try to explain to you, what is the thought process or the basic fundamental that one got to understand regarding this, that what happens between day 3 to day 5? Why is it so challenging? Just imagine embryo sitting on an aircraft, and then suddenly it transitions from a passenger to a pilot. That's what you have to understand. That up to day 3, it's the mother and this that drives the journey. And after day 3, the embryo must fly the aircraft itself. So it has to activate its own machinery. And if it doesn't do that properly, then you have arrest. So that's called embryonic genome activation. Or they say the embryonic block that occurs after day 3. So it's the onus on the lab and different protocols to overcome this particular block. Why? This slide is probably very important because, what happens is genomic activation, embryos, switches from maternal to self-control. If it fails, you have development arrest. Then there's compaction, which if it doesn't happen, you have poor morula. Then there's an energy shift. You need a lot of energy for the cells to multiply and form the blastocyst. If that doesn't there, then you have slow growth of the embryos, mitochondrial activation and cell differentiation. So if anybody wants to know, why this day 3 to day 5 transition is challenging, these are the different points that you got to understand. So I told you that I gradually transitioned from day 3 to day 5 in many cases, and selectively. I'll just try to tell you why, I just did this, 3 reasons. Single embryo transfer, improved pregnancy rate per embryo transfer, and useful for, techniques like PGT. You have PGT now, and, there's now recently the PGT-P that is coming up for polygenic disorders. So all these things are coming. So more and more patients will ask to be submitted to PGT. So, you have to culture to blastocyst. Regarding pregnancy rates, clinical pregnancy rates, implantation rates, live birth rates, generally live birth rates will be similar between day 3 and day 5 transfer, that's the thing. But the clinical pregnancy rates and the implantation rates are definitely more than this statistics. Now, these are statistical slides which show, the clinical pregnancy rate is more with blastocyst. Then, cumulative pregnancy rate is more and definitely with blastocyst. Large studies. But more than those statistics, what is written on this slide becomes more important. Like for example, if you see a Cochrane review, 2016 and 2022, simply if you can read through what is written here, that, if 29% of women achieve live birth rate after day 3 transfer, 32 to 42 would do so after a day 5 transfer. So isn't that important for me? Suppose I'm doing 100 cases, that makes a big difference for me as a clinician. Similarly, if I'm looking at clinical pregnancy rate per embryo after fresh ET, if 36% of women achieve clinical pregnancy after day 3 transfer, 39 to 46% would do so after day 5 transfer. So this is the type of statistics that was convinced me that we should definitely try to transition from day 3 to day 5, because remember it's not the sometimes you don't get the odds ratio and those kind of things correct. Yeah, interpretation of what is there in the statistics should help you to guide your practice. And then again there's you want to reduce multiple embryos. See, come on, this has to be a thing. You can't be very proud that you're getting triplets and quadruplets. That is there. It's not that blastocyst will not give you twinning. It does give you twinning, but then it's always good strategy to a blastocyst transfer to reduce the multiple. And similarly, PGT, I was telling you about PGT, the structural SRPGT, the aneuploidy PGT, and now coming up latest is the PGTP, or the one for polygenic disorders. So as technology evolves, there are new things that are coming up, and then this PGT is going to come. And if you want to do a PGT, you have to do a blastocyst. PGT is no longer done in day 3 embryos. This is very important to understand. See, a blastocyst biopsy will give you more cells, less mosaicism, relatively cheaper, and improves live birth rate. Very easy to understand. It's not a day 3 embryo, but a day 5 embryo. So what are the advantages of a day 5 blastocyst transfer? That it's natural selection, better assessment, visible differentiation, and for genetic testing. Higher implantation rate, reduced multiple pregnancy risk, better synchrony between the endometrium and the lower miscarriage rates, and freezing advantages definitely. But is it without concerns that just because I'm doing blastocyst transfer, am I not having any, problems or issues? Yes, there are issues. You should have a very good lab to culture blasts, especially for people who are poor responders and who are few. There is cycle cancellation due to non-formation of blast, which is an issue. Sometimes you get fewer embryos for freezing. There's this concern for altered sex ratio, the perinatal outcomes. So these are all concerns that are there. And I'll just explain to you in simply this thing, that sometimes, unpredictable blastulation rates, you try and culture up to day 5, sometimes it doesn't happen. This is just really doesn't happen. So what happens is, if 1% of the women have no embryos transferred in planned day 3 transfer, 2 to 4% will have no embryos transferred in planned fresh day 5 transfer. So there's a real possibility that you will not have testing. And you have to have optimum laboratory conditions to overcome that block that I was telling you from day 3 to day 5. So you have to really have dedicated lab people and optimum lab, this thing. So blastulation rate, the number of embryos that will be converted into blasts. What about, you see, when you do a day 3 or day 2 transfer, you have many embryos. You can tell the patient, I'm transferring 3 and I have 3 or 4 more for freezing. That may not happen in the blast. The reduction in the cryopreserved embryos is one of the issues. So if you see, see again, I just take out the interpretation from the statistics, that if 60% of women have embryos frozen after day 3, only 37 to 45 would so have after a day 5 transfer. So you can't, that is one thing that is deficient in this. Then there's this concern about monozygotic twinning. Though it is rare, it is there. So there is this potential for monozygotic twinning, but you must remember that because of that, there is no comparison between the multiple pregnancy rates between a single blast transfer and a day 3 embryo. Another point that's often talked about is altered sex ratios. Blastocyst favors male birth than day 3 embryos. There are a lot of articles like this, which may make the PNDT people sort of squirm, that regarding this. But this is true, and there's a few statistics to that effect. Similarly, the more the number of days you keep the embryo outside in the lab, there is a risk of imprinting disorders, growth disorders such as, Beckwith-Wiedemann syndrome, Silver-Russell syndrome, so large for gestational age. So all these things happen, the risks are there. The perinatal risks are there of culturing for a longer number of days outside the, So what shall I do? Because all these problems are there, shall I return back and go back to my day 3 transfer and, do all day 2, day 3 transfers? And have the premise that human embryos will survive even if replaced prematurely. So this is the premise on which the day 3 transfer is based, So that Advantages, what are the advantages? Natural environment, uterus is a better incubator, early return to uterus, selection simplicity, higher transfer rate, reduced lab requirements. These are all advantages of the day 3 transfer. But remember, the day 3 transfer also got its flip sides. So allowing embryos to grow to day 5 weeds out the weaker ones. The day 3 ones will not have that advantage. Similarly, you have low implantation rates and higher risk for multiple pregnancies. That's a concern. I think we should be concerned about these things, not just about our results in IVF. We should also be concerned about these kind of things. So that's very important to understand in the talk. So I just lost my picture.
Just click on the slide. We can see it.
Yeah, but I lost it. The slides, I lost it.
We can stop sharing and share again.
Yeah, I'll do it. Just a minute. Shall I share again?
Yeah, please.
Is it seen?
Yeah.
Yeah, no? Yeah.
Yeah.
So I'm sorry for that. So that was the flip side. And now, so what about blast? So what I do is individualize. I don't have any great yardstick. So blast, I will transfer for a young woman with good ovarian reserve, where I'm sure I'll be able to culture to blast. Patients with high number of good quality embryos on day 3. Patients who want pre-implantation genetic testing. Those who want a single embryo transfer. Previous IVF failures at day 2, day 3 transfers. So all these things, where I will go in for blast. What about day 3 transfers? I will go for day 3 transfers when women with poor ovarian reserve, more than 38 years age with limited number of embryos, very few embryos, where, I may run the risk of not having any embryos for transfer. Previous blastocyst arrest or failure to reach the day 5 blast. Less experience or resources for prolonged embryology culture. See, it's about resources, about how many days the embryologist stays with you. If the embryologist is going to stay with you only for about 2 or 3 days, there is no use for dreaming of doing a blastocyst transfer. So these are this is how I individualize. So I'll just conclude that, transferring embryos at day 3 may provide the same benefit as day 5 embryo transfer to patients. However, more embryos were required to be transferred to achieve the comparable results. This is a very important message. Nobody who is doing only day 3 need to feel inferior about, the fact that you are not doing a blastocyst transfer. Day 3 and day 5 transfers both have specific advantages, and the great secret lies in individualization. And individualization first should depend upon few things. Most important is the patient characteristics, the embryo quality and quality. You should be very realistic about the logistics in your clinic, your lab capabilities, about the number of days your embryologist is going to stay with you. All these things are very important. And a previous treatment history. Like, for example, if previous you transferred day 3 embryos and it didn't work out, then, you have to offer something else to the patient. Otherwise, that's not good medicine. So this is, so like I say, optimal approach lies in individualization and in personalized decision making rather than a one size fits all protocol. So this is true not only for blastocyst versus day 3 transfers. This is true also for every aspect of reproductive medicine, like stimulation, all aspects. So thank you very much for the opportunity, and thank you for a patient hearing. And I hope that you gathered a few points along the way.
Thank you so much. That was excellent, Dr. Venu. And I would request Dr. Shalini. Shalini, you're there?
Yes, I'm there. Can you hear me?
Yeah,
excellent
contribute.
presentation, Dr. Venugopal. It is always a dilemma whether to go ahead when you have few embryos to go ahead with the day 3 transfer. But yes, going to day 5 improves your success rate. So yes, any comment about the day 3 and day 5 comment? You do a dual transfer?
No,
you do a transfer.
I am not a big fan of that
Okay.
particular thing, because again, see, I said that I will be doing a blast and this thing for decreasing the multiples. The dual transfer, sometimes what happens is you end up with multiples. But I know there are people who do that and this thing. But personally, I am not.
You would not go ahead. Yes, the literature
thank
also
you.
does not support. Okay.
So
Thank
they're
you.
already
Thank you, Dr.
running
Shalini.
half an hour late.
Yeah. So, Dr. Sonal, are you there? You can introduce the next speaker, Dr. Poonam Goyal. Dr. Sonal?
Thank you, Dr. Poonam, for agreeing to speak later.
Very nice, sir. It's my pleasure.
Dr. Poonam Goyal is well known to all of us. She's a member of ISAR. She's part of FOGSI as well. She's a FOGSI chairperson. And we've had the good fortune to work with her as coordinators for the RM course a couple of years back. Formal introduction from Dr. Sonal.
Sir, हो गई.
Thank you, Pratik Tambe sir and Sheila Mane ma'am for giving me this opportunity. Dr. Poonam ma'am is going to speak about the luteal phase support in ART cycles. And ma'am, as sir said, she is well known to so many of us and she is chairperson of Safe Motherhood Committee also. Ma'am, I welcome you on behalf of ICOG.
Thank you.
Congratulations to Pratik Tambe sir. आपकी बहुत अच्छी CME हुई. Every day there is 670 to 660 participants. Congratulations.
After 1 hour, there'll be even more because they will need to do the third day's post test.
So should I share the screen?
Please, ma'am, go ahead.
So just a minute. So first of all, thanks to Dr. Pratik sir, Dr. Sheila Mane ma'am, Dr. Rita and Dr. Kanti Bansal ma'am, and pranam to Dr. Jayam ma'am. So let me start with the luteal phase support in ART pregnancies. So the luteal phase is the second half of the menstrual cycle. Just 1 second. The time after ovulation and before the next period, it usually lasts for 12 to 14 days. So why the slides are not moving?
Just click on the slide, ma'am. It will move.
Okay. No, yes. So the hormonal baseline of the natural cycle is that there will be LH peak. LH peak will lead to ovulation, and then there will be progesterone. Progesterone structurally dominates the luteal phase, peaking the mid phase, and before dropping ahead of the menstruation. So, but when we do the controlled ovarian stimulation, it directly disrupts the natural endocrine physiology, and there is profound LH suppression, which is driven by GnRH analogs, and there is failure of corpus luteum. So in IVF cycles, because of lack of this LH surge, there will be luteal gap, which is the critical hormonal insufficiency. So without exogenous luteal phase support, the luteal gap results in implantation failure and early pregnancy loss. So luteal phase is a vital component of ART procedures. The luteal phase occurs after ovulation. In natural cycle. The corpus luteum secretes the progesterone to prepare the endometrium for the embryo implantation and maintenance of early pregnancy. In ART cycles, controlled ovarian stimulation, oocyte retrieval may suppress the natural progesterone production, and it results in luteal phase deficiency. To overcome this, progesterone supplementation is administered through vaginal, oral, intramuscular, or subcutaneous routes. So progesterone, we know, is the architect of the luteal phase. This is responsible for the steroidogenic activity of the corpus luteum, responsible for implantation, increasing the receptivity of the endometrium, and producing the growth factors and regulating them. So the luteal phase support will improve the endometrial receptivity. It will enhance the implantation rate. It will increase the clinical pregnancy success and reduce the risk of early miscarriage, making it essential for fertility treatment outcomes. Now, what is the physiology of luteal phase? After ovulation, the corpus luteum secretes progesterone and estrogen, which plays an essential role in preparing the uterus. Progesterone converts the endometrium into secretory and receptive state, allowing successful embryo implantation. During early pregnancy, HCG is produced by the developing embryo and maintains the corpus luteum and supports the continuous progesterone secretion until the placenta takes over. So how it happens? First, you will have ovarian progesterons, then these progesterons will start falling, and by the same time, the placental progesterone will start increasing. From 4 weeks, it will start increasing to 7 weeks, and some of the hold is then gone to the placental progesterone. So when we remove the corpus luteum before 7 weeks of gestation, it guarantees the pregnancy loss. 8.1% of normo-ovulatory cycles will also have luteal phase defect. So what actually it is the lack of more than 2 days in endometrial development as compared to the expected day of the cycle. Suppose if our expected day of cycle is day 25, then the actual your day of that cycle will be day 22 or day 23. So that is how. So how do we require actually tissue diagnosis for exact confirmation. We need to do endometrial biopsy daily from day 21 to 25 to see when the endometrium becomes receptive, and we will find the lack of 2 days in this, and it is to be done in 2 different cycles. So this all is very impractical. So that is why instead of doing this, we are doing the luteal phase support. So in natural cycle, why it happens? It happens because of the disordered folliculogenesis, defective corpus luteum function, abnormal luteal rescue by the early pregnancy, and sometimes there are conditions like hyperprolactinemia, hyperandrogenic state, significant weight loss or weight gain, and severe athletic training, and high systemic stress. In all these conditions, there will be luteal phase defect. Now in ART cycles, there are several reasons why this is happening. One, we have already discussed the controlled ovarian stimulation, and then there is reduction in natural support of the corpus luteum. The use of GnRH agonist and antagonist protocols further decrease the endogenous LH levels. During oocyte retrieval, aspiration of granulosa cells reduces the progesterone producing cell mass. Additionally, the supraphysiological levels of estrogen and progesterone generated during stimulation exert negative feedback on the HPO axis, and it further impairs the luteal function. So the etiology is mainly iatrogenic in these ART cycles. The severe iatrogenic luteal phase defect, which requires exogenous support to maintain corpus luteum activity, VEGF-A and FGF2 upregulation, and implantation of the cytokine production is required. So these combined effects lead to inadequate progesterone production and impaired endometrial receptivity, making luteal phase support a very essential part of. So here you see the histological proof which mandates the luteal phase support. Without luteal phase support, you see such a poor or there is lack of secretory activity in the endometrium. And once you give the luteal support histologically also, you see the improvement and you see a beautiful secretory endometrium which is receptive. And for a normal pregnancy, you need secretory endometrium, adequate thickness of that endometrium, good endometrial blood flow, and then supportive immune response also. So luteal phase cannot be ignored in ART. And our lifesaver is progesterone. It is strictly recommended for luteal phase support in IVF and ICSI cases, and exogenous progesterone is entirely responsible for inducing the secretory transformation of endometrium, preventing the delayed maturation and rescuing the pregnancy prior to 7 weeks when the luteoplacental shift happens. So now coming on to progesterones. Now that we have decided that we need to give progesterone to these patients. Now progesterone is the micronized or the natural one is synthesized from the plant source. The plant is Dioscora villosa, and the other one we have the endogenous progesterone related products which are synthetically prepared like dihydrogesterone, and we have other progestogens also which we don't recommend in pregnancy because they change to testosterone in their metabolism. Now the role of progesterone is to make the endometrium mature, to stabilize the endometrium, and make the endometrium receptive for the embryo implantation, regulatory inflammatory mediators to create the adequate positive immune response in early pregnancy, and preventing the early pregnancy loss. So what are the agents for this LPS? We have got progesterones, we have HCG, we have GnRH agonists, and estrogen supplementation in selected cases. Now, progesterone preparations. Intramuscular progesterone in oil achieves higher serum concentration, but injections are very difficult for the patient because of pain and discomfort and all. And oral dydrogesterone often improved, and it is very much patient compliant. And subcutaneous aqueous progesterone is the newer alternative that we now have, and it is little comfortable to the patient. Various progesterone preparations are used for luteal phase support in assisted reproductive technology cycles, and vaginal progesterone is available as gels, capsules, and pessaries, and it provides the direct uterine effect with good patient tolerance. Vaginal route provides the direct uterine effect, bypassing the circulatory, liver, etc. Then intramuscular route achieves high serum level. Oral routes offer better patient compliance, and subcutaneous route is increasingly becoming popular now these days. Now, what ASHRAE says? ASHRAE says that yes, progesterone is recommended for the luteal phase support. Any of the previously mentioned administration routes like non-oral for natural progesterone as luteal phase support can be used. Now, what should be the timing and the duration? Luteal phase support usually begins at the day of oocyte retrieval, or you can go up to day 3, not later than that. It is continued until pregnancy test or 8 to 12 weeks of gestation. Usually we give it up to 10 to 12 weeks of gestation. Timing may vary depending upon the protocol of your center or according to your practice. Now, on the day of the trigger, you measure the progesterone levels. If they are less than 1 nanogram, it is a good endometrium and there will be synchrony and you can go ahead with the fresh transfer. But if the levels are high, then there will be dyssynchrony and you should not transfer the embryo and do the freezing and then later on transfer the embryo. Now, starting of progesterone according to ASHRAE is also the same. There is a window that you start from the evening of the day of oocyte retrieval and day 3 post oocyte retrieval. Progesterone support should be administered until at least they say up to pregnancy tests, but recommended is that you give it at least up to 10 weeks of gestation. Now, what are the dose? The dose is 50 milligram once daily intramuscular injection, which is aqueous preparation. Then there are the traditional preparation oil-based 100 milligram. You can use 25 milligram daily for subcutaneous progesterone, 90 milligram once daily for vaginal, 200 milligram 3 times daily for micronized, then 100 milligram twice or thrice a day for micronized vaginal progesterone preparation, 400 milligram vaginal pessary or vaginal capsules. You can use every kind of progesterone is available. Now, deficient progesterone is equal to inadequate immunoregulation. So, progesterone produces progesterone-induced blocking factor. PIBF is an immunomodulator protein which induces the T helper Th2 response and it restores the balance between the Th1 and Th2 cells. So PIBF has an important role in maintaining the pregnancy. The increased PIBF leads to healthy growing of pregnancy. So that is why we use this oral dydrogesterone. Oral dydrogesterone is considered to be an immunomodulator, and so it is being used. And ASHRAE also recommends the use. So you can use it 20 to 30 milligram per day. Safety is not any concern. It is the drug is very safe and we have been using it for, I think, ages. Now, coming on to HCG for luteal phase support. The efficacy, they say, is wonderful. It is exponentially successful, but there is always a risk of OHSS. So, Ashray says in HCG trigger ovulation stimulation cycles, the luteal phase support with this HCG 1500 is strictly not recommended. The older Cochrane data, however, showed that pregnancy rates are very much higher, but again, the unacceptable danger, which we don't want. So that is why a strong no to use HCG with your progesterone due to severe safety profile if you are doing fresh transfer. Now coming on to GnRH agonists for this luteal phase support. There were various studies of using this with progesterones, that bolus was given, then repeated injection. But the clinical studies have found that there is zero clinical yield. That means there is no significant difference in the live birth or pregnancy rates. So in GnRH agonist bolus, in addition to progesterone for luteal phase support in HCG triggered cycle, is probably not recommended. This is what Ashray says. Now, some special scenarios, like unlike the prolonged LH-like activity of an exogenous HCG trigger, a GnRH agonist trigger provides only a transient endogenous LH surge, leading to profound and rapid luteolysis. So the standard exogenous progesterone alone is frequently insufficient to rescue the luteal phase in these cycles. The mandate is that then GnRH agonist trigger cycles require specialized luteal phase support strategies, or they require the freeze-all approach to have the complete absence of long-acting HCG signal. Now, giving LH to progesterone for luteal phase support can only be used in the context of clinical trials for the research purpose only. That is what is Ashray's recommendation. Now, giving estrogens, adding estrogens to progesterone for luteal phase support is probably not recommended. This is what is Ashray's recommendation. Additional E2 to standard progesterone will not help. And sometimes when we just, I think 2-3 slides more. So whenever there are supraphysiological levels of estrogen and you are planning a fresh transfer due to any reason, then the levels will suddenly fall after your ovum pickup. In those particular few patients, you can give a tapering of kind of dose of estrogen. So in frozen transfer, we are already using this. Now, complications and limitations. The progesterone supplementation may be associated with injection site pain, that we all know. Vaginal pessary may cause local irritation, and patient compliance is sometimes becomes very challenging because the prolonged duration of the use of this drug. Additionally, there is still a lack of universal consensus regarding the optimal regime. Kya dose deni hai, or what is the route and everything. There is no, I think every center has their own protocols. Now, what are the future perspectives? The emerging approaches like AI and biomarker-based optimization are being explored to predict the implantation. These innovations aim to enhance the embryo endometrial synchrony, improve implantation rate, and provide more precise evidence-based management in IVF cycles. And personalized luteal phase support strategies are increasingly being adopted in ART to improve the pregnancy, and serum progesterone monitoring plays an important role in assessing adequacy of luteal support, which most of the times I think not all of us are not doing this. Now, to summarize, we need a pre-retrieval check of progesterone levels. Then we go ahead for deciding the transfer, and then we give the luteal phase initiation, which we start from the day of the trigger or day 3 post retrieval of the day of the OPU or day 3 post retrieval, and the duration is again for 6 to 10 weeks of after you start it. Up to 10 weeks, I would recommend. Then dydrogesterone, you can use other alternatives if you don't want to use injectables. And agents which you should avoid mostly are adding estrogens, HCG, and this GnRH agonists. So these are again those doses. So every heartbeat in ART begins with implantation, and every implantation depends upon the judicious luteal support. Thank you.
Thank you, Dr.
Thank you.
Poonam.
Thank you.
Fantastic
I will
presentation,
stop
lovely
share
slides.
myself. Thank you, sir.
That was
Thank you very
excellent,
much.
Dr. Poona. So,
Yeah.
Dr. Shalini, you want to say? Yeah.
Yeah, excellent presentation and beautiful
Thank you, ma'am.
slides.
Thank you, ma'am.
I just want to make one comment that dihydroprogesterone definitely is a drug for the luteal phase support. But when it comes to early pregnancy, the DCGI, the FDA, and the UK, none has actually approved it for the early pregnancy. So we know we are using it, we don't have complications, but
Yes.
this knowledge should be there for every, clinician. Yeah. That's my comment.
Thank you. Point well taken. Excellent presentations by all four
Thank you,
speakers.
sir.
We are half an hour late. Can I
Yeah. So
request
I
the
think
moderators of the panel, Dr. Ritu Khanna and Dr. Kundan Ingle, to please switch on their video and get started. I saw Kundan logged in.
yes, he's logged in, and
I
so
hope he
Dr.
doesn't
Kundan
have a
will be
seatbelt
taking
on.
forward because I'll have to just log out for some emergency, sir, and Dr. Kundan will take over the panel.
No worries. So Dr. Kundan Ingre is our infertility chairperson of FOGSI. He also is part of the Maharashtra chapter of ISAR and the national ISAR. He's well known to all of us. He's contributed a lot to the growth of knowledge of infertility throughout this country. Thank you, Kundan, for joining us. Dr. Ritu Khanna is the co-moderator. Unfortunately, she has an emergency and she has to leave. As you know, she is one of the coordinators for today's program. Dr. Ritu is currently Vice President of IFS, and she is also a very important part of the ICOG because she is an ICOG Governing Council member. She was chairperson of the Food, Drug, Medical Surgical Equipment Committee. Next slide, please. We have two experts today. Dr. Asha Bakshi is Vice President of ISAR. She is also served as the Vice President of FOGSI, and she is the founder chairperson of NTIAG and ISAR. Thank you, ma'am, for joining us as an expert. Next slide, please. We have with us Dr. Neelam Puri, who is a past chairperson of the UP ISAR. She's the secretary of UP IAG and a past president of the Varanasi OBGYN Society. Two very distinguished senior infertility consultants who are stalwarts in the field of infertility here as experts for this panel. And we have our panelist, Dr. Radha, is the joint secretary of TAPISAR in the past, and I think she is one of the team that has helped us to organize the one-year reproductive endocrinology reproductive medicine exam in Chennai earlier this year. Thank you very much, Dr. Radha, for being a center head and for all your contributions. Dr. Padmaja has an extensive CV, but I will introduce her from what I know her. One of the first visits that I had, national visits about 15 years back, was to Vijayawada when I was introduced to her. She's a leading infertility consultant from Vijayawada, part of the PCOS Society and also part of the local ISAR. Thank you, Dr. Padmaja, for joining us. Dr. Anuradha Kar is not able to join us. She is from Bangalore and a leading infertility consultant there. Dr. Sini Venugopal is from Bhubaneswar and she is also a cosmetic and regenerative gynecologist, besides being presented with multiple awards in the field of infertility. Next slide. Kalyani is here with us. I think Kalyani is from Indore, well known to us. She's the head of the NOVA IVF there. I've known Kalyani for, I think, last 20 years now. She looks exactly the same. She hasn't changed. She hasn't aged a single day. So she needs to share that secret with us as well. And last but not least, we have Dr. Deepti Gupta. She's currently the secretary of FOGSI. She's now the vice president of Jabalpur OBGYN Society. She's also served FOGSI in various different capacities, notably the quiz committee. Thank you very much, Dr. Deepti. And where is our moderator? Moderator is missing. Maybe I need to give him a call.
He's there.
Kundan, hi, thank you for
Kundan
joining.
is there.
Otherwise, I would have had to do an impromptu panel.
No, I'm here. I'm just.
So the panel is supposed to be on optimizing IVF success, and this is going to try and put together everything that we learned during the course of today, practical hints, tips, and case scenarios. Over to Dr. Kundan.
I think welcome all the stalwarts. Thank you. Thank you all for accepting.
Thank you,
Good
madam.
evening
Thank
to
you.
all of you.
Thank you, Madam and Sir, for the
Dr.
opportunity.
Thank you.
Dr.
Yeah,
Kanti,
thank you everyone for giving us this opportunity.
Dr. Asha.
Give me 1 minute. I'm trying to open the PPT. Just give me 1 minute.
तुम्हाला पाहिलं की विठ्ठलाचीच आठवण येते मला आता.
So for the benefit of those in the audience who are waiting for the post test, we will try and do a panel which is short, about 30 minutes. So about 5 minutes past 7 is when we might start the post test. Over to the moderator.
कैसे खाना है ये अभी फिलहाल के लिए मैं कल बात करता हूँ सेशन चालू हो रहा है तुम्हारा रिपोर्ट लिखा है सब कल फोन करो ओके सर चलो थैंक यू So, welcome all the panelists. Thank you so much, ICOG FOGSI President Dr. Bhaskar Pal and Pratik. Thank you for giving me this opportunity to conduct this panel discussion on optimizing IVF results. I hope I am loud and clear.
We can hear you. Maybe you can move a little closer because I think you're not wearing the earphones.
Can you hear me now? Clear?
We can hear you. No worries. Go ahead.
Okay, fine. So we have our experts, Dr. Asha Bakshi and Dr. Neelam Ohri, and we have panelists. Welcome all panelists: Dr. Radha, Dr. Padmaja, Anuradha, Venugopal, Kalyani, and Dipti Gupta. So we know that the spectacular achievements is always preceded by unspectacular preparation, and we are going to discuss about certain preparation ourselves to to optimize our success rate. And for all the audience, it is very important that what you mean by optimization is nothing but we are trying to get a maximum success rate. So today if we look at the average success rate, we easily get around 55 to 60% pregnancy rate, but we are looking at how can we maximum this success rate to 70 to 75% outcome of your IVF treatment. Now this is a simple comparison. So always when I talk to the patient, I always say there are 8 steps for natural conception. One is a follicular growth, second is a ovulation, third is a oocyte pickup, then fourth is a transport of sperm from vagina till the oocyte, then fertilization where the oocyte is penetrated by sperms, and then embryo is formed in the fallopian tube. This embryo is transported from fallopian tube to the uterine cavity, and then it implants in the endometrium. Now if you compare natural conception with in vitro fertilization, we are almost doing till the 7th step in IVF, but one step we can't do, and that is implantation. And that's where our most important step of the success is how can we get a natural implantation. And if we get a natural implantation, our success rate is going to be much better. We know that for successful implantation we need migration of the embryo to a suitable implantation site, attachment of embryo to the superficial endometrium cells, penetration of the embryo into the deeper cells, and then invasion of embryo into the endometrium or spiral arterioles that establishes a intact blood supply to the embryo.
Kundan sir, sorry for interrupting. There are complaints that the volume is low. Maybe you can raise your device volume.
Okay, just a minute. Then I'll do that. Give me 1 minute.
Or you can wear your AirPod.
Okay, no, I think I can microphone speaker. Yeah, okay. 1 minute. Can you hear me now clearly or no?
Not that great. We can, but.
Okay. Audio settings, 1 minute. Output volume, test speaker, microphone. Can you hear me now?
Yeah.
It's
better. Much better. Thank you.
Okay. I think it was a setting problem. Okay, so let's go back to the so implantation is a really a very important step, and we know that for successful implantation we require a receptive endometrium, we need a very good blastocyst stage embryo, and a complex sequence of signaling events which happen between maternal and embryonic tissues, which actually facilitate the implantation of a blastocyst into the receptive endometrium. So keeping this in mind, these are the very important steps of optimization of success rate, and that is selection of your patient for the IVF, what adjuvants you are using before IVF, what kind of embryo quality, what kind of endometrium receptivity and better endometrium receptivity, and we will also discuss about fresh versus frozen embryo transfer. Now I'll begin with Dr. Radha Vembu. How does you select, when it comes to optimization, what are the important steps in terms of selecting a age related patient for IVF outcome? Means how does that age affects the IVF outcome? Can you give some light on it?
Yes, age is one of the important factor which contributes. It's not only the maternal, it's also the paternal age. So if we take the female factor age less than 35, the reserve is also good. The risk of aneuploidy is also less. And as the age advances, the quality of the oocyte, it goes down, and the risk of aneuploidy is high. And even the male partner, if the age crosses 40 or more than 45, they do have certain impact on the ART outcome. So I consider age of the couple as one of the important criteria for the success of an ART.
Absolutely, and I think you have pointed out very rightly, the more younger the patient, the more better reserve as well as more better oocyte quality, and the more older the patient, the reserve goes down as well as the quality of the oocyte also goes down. I think it's very important, and you can see the influence of age on oocyte euploidy rate. This is a good picture where they have shown that very clearly, that as the age advances, the euploidy rate goes down and down significantly, where you can make it out that after 36 this graph is going steeply down, and after 38 in fact the euploidy rate is really go down around 20%, and at 41 age it is just 10 to 12%. So we have to remember that when it comes to optimization, you can't expect 41 years patient or 41 year age group patient will give a same pregnancy rate what 26, 28 or 30 years age group patients will give. So again, when it comes to optimization, you have to give really realistic values to your patient. Sometimes when you are seeing a couple which is around 40 years old and husband is 45, you can't say that you have a 80% pregnancy rate. That's totally kind of overestimation. And the problem is that there are mitochondrial function impairment, there are granulosa cells apoptosis which is increased, and there is oxidative stress increase. So all this will affect energy supply to the oocyte, the quality of the oocytes, and all that is very important, and that's why your selection of the patient is important. Now when it comes to optimization, we know that embryo quality, one of the pillar on which the success lies is the embryo quality. We know that we'll get a good embryo quality if we have a good oocyte and we have a good sperm. So let us focus on those points. How can we get better oocyte quality and better sperm quality? So Dr. Padmaja, I think you can throw us some light that why do we divide these patients into these three categories: normal responders, hyper responders, poor responders? Why do we need to do this? Was there any impact on the IVF outcome of these particular things?
There was a very good study by Sunkara Sesh, who analyzed because they had the big data analysis. They analyzed all the IVF cycles and they said, how many eggs do we need to make a baby? So they found that when the data was analyzed, the pregnancy rates, that means using fresh, frozen, cumulative, one IVF pickup we do, we get a pregnancy. So how many? So 15 was the sweet spot. So when we had up to 15 oocytes, the pregnancy rates continued to increase. After that, even the cumulative increased. So then when they said, how do we get 15? So if we just keep increasing the gonadotrophin dose, will we get 15 oocytes in everyone? That's not going to happen. As Dr. Radha said, and as you pointed out, we are only going to be able to grow the follicles that are decided to grow in that phase. So those are most likely the number of antral follicles we are going to see, and that is going to be reflected in the AMH value also. So we know that someone who has less number, if there are only 4 antral follicles, the maximum you're going to get is 4 follicles. You're not going to get 20. So, and now when we're going to get only 4, there's no point in giving her a 600 dose or something like that gonadotropin, because the threshold is maximum you can give. Ideal is around 300, 450 is the maximum. So using more than that is not going to give us. So we need to divide our people in our mind. Are we expecting less? Are we expecting a good number? Are we expecting, especially in PCOS, if we are going to go full blown and they have around 40 to 50 antral follicles, they're going to have 40 to 50 follicles that are growing if we give a high dose. So in our mind, we need to optimize the dose, we need to tell them the prognostic value, and we need to avoid complications. If we give a normoresponder low dose, she is going to become a poor responder. So for that, in our mind, what are the number we are expecting? Where are we starting? How much dose we give, and how do we avoid complications? So that's how we divide into poor responders, normal responders, and hyper
Yes, so Padmaja has really given us an insight about why and how this classification actually help us to identify. Because see, this is important because many times we see a recurrent implantation or IVF failure patients, and we have to always go into their previous details of their previous cycle, that was she given only 150 dose and that's why she gave you 4 oocytes, but her reserve is much better, she would have given you 10 to 12 oocytes. So because the starting dose was low and gonadotropin total dose consumption was low, and that's why she gave 4 oocytes. So she was not a poor responder, she was a normal responder, but the starting gonadotropin dose was poor. So all those things are important, and that's why whenever you are selecting your patient, you have to categorically select them, and depending on your that category, you need to follow certain strategies which we are going to see now, that how after dividing our patient into these 3 categories, how the strategy is different, how the adjuvants different, because that's what she has already pointed out. So let's begin with this patient, first patient, in fact the third group, who is a hyper responder, which is going to give us more than 15 oocytes because her reserve is like that, or probably previous ovarian response to her in her previous cycle, she gave us 22 oocytes, so she is a hyper responder. But now I have to do her fresh cycle. What are the strategies to get the better quality oocyte in hyper? We know that majority times the hyper responders are the PCO patients. They are the PCOS patient, which is now we call it as PMOS. So there are certain endocrine abnormalities in these patients which will always affect the oocyte quality. So what are those strategies? I think I'll go back to Dr. Sini Venugopal. Sini, please tell us that if you look at any PCOS patient who is going to undergo IVF cycle, what do you do to get that best of the oocyte quality from her? So what are your strategies in your practice? I think Sini is there. I saw her.
She has to unmute.
Sini, can you unmute yourself and speak? If not, then I will pass this message question to Anuradha if she's around. I haven't seen her.
Anuradha is not in the panel.
Okay, she's not there. Okay, and then I think then Dipti, I think you can suggest in what do you do in your practice about this, and then we'll go to the experts also, of course. But what you would have done to get a best of the oocyte quality in these patients?
Sir, PCOS now PMOS patients, again, lifestyle intervention to start with would be important. However, we have to strike a balance. We cannot ask the patient to wait for so many months to achieve a certain weight profile or whatever. And of course, if there are any underlying associated metabolic abnormalities, they have to be looked into. And the standard recommendation is for an antagonist protocol, we have to avoid HCG trigger. And like the previous discussion took place, that a fixed day antagonist protocol is considered better than a flexible antagonist protocol. And then of course we have to do a freeze all cycle. And adjuvants में sir metformin can be considered to improve oocyte quality as well.
Okay, so my question to our experts now, I think I can see Dr. Asha is there. Asha madam, can you throw us the light? She has covered, say, lifestyle modification, insulin sensitizers. Do you feel anything else which will work in this patient that we should consider? Maybe its contribution might be very less or maybe minimal, but do you think that more strategies can help us other than insulin sensitizers and weight loss?
I think it's very important to keep LH also under control. So just before starting the cycle, I usually tend to check the LH and progesterone levels also.
Okay.
And if LH is really very high, then sometimes I tend to cancel the cycle, or I may give antagonist for 3 days and then start the stimulation.
Okay.
Besides that, people are talking about mitochondrial energizers even in PCOS patients, and they are giving CoQ, NMN, and people are also giving NMN, and lots of things are coming up because it is surprising that even if the patient is young and then you did a good protocol and everything, and you take out the eggs and give to your embryologist, she will make faces and say, your eggs are not good. So I don't know what is going on. In the past, they were not so experts to tell us that eggs are not good, but that is one thing we are facing, that the quality of eggs which we are getting is not that good. So probably all these things are important. Metformin, myoinositol, lifestyle, and all these things are quite important.
Yes, I think as expert, Dr. Asha has elaborated very nicely that there is a role of mitochondrial energizers and antioxidants along with the folic acid and vitamin B12. It has been studied that in PMOS patients, those are the PCOS patients, they are also having hyperhomocystinemia, very common in those patients. So inflammation is one of the very important thing. As Dr. Dipti said, weight loss very important, adjuvants like metformin and myoinositol. These are the studies way back in 2025. They found that if the serum folic acid and vitamin B12 levels, if they are in a highest quartile, then I think these patients will have a very high possibilities of live birth. And even if you look at the supplementation of micronutrients before IVF cycle, they have seen that follicular fluid and serum proteins were protected from oxidative damage, and even the mean number of good quality oocytes were significantly increased. So there is a role of micronutrient supplementation and antioxidants, and even the giving insulin sensitizers, they found that higher number of good quality M2 sites were observed when you have given myoinositol and metformin in combination. Now coming to the next category patient, that is strategies to get better quality oocytes in poor responders. So I think Dr. Kalyani, is she there? Kalyani Srimali? If she is not there, then I think we will again go. Is she there?
Send her an unmute request, yeah.
Okay.
Yeah,
So,
I'm here.
Yeah, hi
Can you hear
Kalyani.
me? Hi.
Kalyani, we have divided our IVF patients into hyper responders, normal responders, and poor responders, and we understand that the extreme corners are always troublesome. So hyper responders and poor responders are the one who troubles when it comes to getting oocyte quality. So what strategies you will follow to get a better oocytes in poor responders, means before even planning and starting your cycle. What is in your mind on this?
So the first and the foremost in the poor responder would be thorough counseling with the patient to make them understand what they are going to go through it. The second would be to divide them into the Poseidon criteria: age less than 35, age more than 35, with the AMH level of low and AFC count of less than 5. And then of course I would start preparing them. One is of course always the lifestyle modification is most and the important thing. It can be poor, high responder, or even the normal responder. So lifestyle modification, making them understand the importance of it is important. The second would be to put them on good energizers like antioxidants, maybe CoQ, and nowadays we have the other molecules also which has come into the market, the niacinamide. The third would be to understand the previous cycles, because of course when they come to you they must have already undergone multiple ovulation induction cycles. Gives us an idea if clomiphene was used and how many number of follicles have gone through. And if we have time for 2 to 3 months, I would also like them to put on the DHEA if available and the patient is okay to wait for 3 months and go ahead with it. In terms of the strategies for the stimulation, probably I'll do is the conventional IVF for them, that is the standard dose of 300 or maybe 375, and add a little bit of LH, not just pure RFSH. I would prefer adding recombinant LH or a combination of HMG. The third would be to use is an flare-up protocol, maybe in case if they have one cycle which have failed in an IVF cycle, to do is a short flare-up cycle for them. And of course, the folic acid and the vitamin B12, and now the vitamin D also plays an important role for them. So this would be my strategy, planning a proper cycle with the counseling part, with proper antioxidant, and then making the patient understand how we are going to go ahead with it.
Okay, so I think it was a very long answer for a short question, but I think you have covered up all the points that it is important that you need to give adjuvants, and I think when it comes to adjuvants, DHA and CoQ enzyme are the one which have proven their fit into this field, that if you give them, then the poor responder or low reserve patients always do well when it comes to oocyte quality. Of course, the folic acid B12 supplementation is there, antioxidants in combination. So before even we start any ovarian stimulation, probably it is important that we need to give them these adjuvants which will really help them. Okay, I am
just one
please.
second. There is also a role of luteal phase estradiol if you can add karke, but there are no proven data showing that we can have a better synchronization or a better. But yes, in the poor responder, we can add is the testosterone gel as well as the luteal phase estradiol support, which I forgot to mention.
Okay, so I think these are all very important ones, because this comes as a we need those few oocytes but good oocyte, that is very important. Okay, before I move on, I am little stuck here because I can't move my slides here. Pratik, can we?
5 minutes left anyway.
Yeah, I know, but this is how can you help me out in?
You can click on the slide and pray that it moves.
No, yeah, it's gone to some other meeting.
Take closing remarks from everybody and close it off.
One thing we didn't discuss is melatonin. People are talking a lot about melatonin also, because that is a very good antioxidant and it is a good ovarian rejuvenator also. So maybe it's worth, and de-stresses the patient while she's undergoing IVF.
Okay, now can we, Pratik, can we take some 5-10 minutes, because it is important to finish some important point. Okay, so how the sperm factor can affect the outcome, because we have understood the oocyte, but how you will handle the sperm factor is because sometimes that semen analysis only not going to help you about the sperm quality. So what more tests you will do it in that case?
Maybe we can think about doing the DNA fragmentation index for such patients.
Great,
To improve, yeah. And of course, nowadays we do have the HbA binding also to understand if the fertilization capacity of the sperms are on the good side. For maybe if we are going to use an add-ons like FOGSI or something, probably we can go ahead and do these 2 tests for the patient.
Yes, so I think one of the very important tests, I think I feel that it is required nowadays, because there are lots of patients who's got a high sperm DFI, and we know that the sperm quality, high DFI does affect the embryo quality, and ultimately it affects your success rate of IVF. And it has been shown in this systematic review that if you have a low sperm DNA fragmentation, it is associated with a significantly higher live birth rate. And we can't go into detail that how you treat sperm high DFI, but I think lots of different strategies, oral antioxidants, treating the underlying pathologies like varicocele and infection treatment, as she mentioned rightly, that we can go by ICSI method instead of conventional IVF, short ejaculatory abstinence, maybe taking sperms from testes, sperm selection techniques, all are going to help us, and they have already proven that these methods, if you follow, then there are good chances that you will be able to select a sperm with the intact DNA. Now coming to the next point, which is the ovarian stimulation protocol is best to optimize IVF results. Now thinking about all these 3 categories, agonist protocol is best or antagonist protocol is best. I'll go to the expert first, because I think Dr. Ovri madam is there. Neelam Ovri madam, can you throw us light on agonist and antagonist?
Sure. So since long we had been using agonist protocol, but now for the last many years we are using antagonist, and now we see that world over the IVF has changed to antagonist protocol because of many reasons. Firstly, it came for the hyper responders, so that we can give the agonist trigger and then freeze the embryos. But now, because of its same results and but it is more patient friendly and doctor friendly and staff friendly also, and gives the same results. So antagonist protocol, I am using it right and left, and very rarely agonist protocol, long agonist protocol in failed cycles.
Great. I think you have correctly mentioned that antagonist mostly for almost all patients, and I think we need to understand that in hyper responders it definitely reduces the OHSS rate and without compromising the live birth rate. So now it has been proven that the live birth rate is same whatever dose, I mean, and antagonist or IVF, and that less OHSS rate is the advantage. And even for those category 4 patients of Poseidon, they have shown that antagonist has given a comparable results with GnRH agonist. So coming to Dr. Siri, if you have joined, I could see you, Venugopal, Dr. Siri.
Yes.
What is your choice, day 3 or day 5 embryo transfer? Does it help for optimization of IVF success rate?
Yeah, definitely. When we compare between day 3 and day 5 embryo transfer, definitely day 5 embryo transfer is the preferred one. That is, if we have like good number of embryos at hand, then definitely we can allow the extended culture to day 5, and then we can at least do a single or maximum like 2 embryo day 5 transfers. But then in cases where we have like less number of embryos and the quality, when we are looking at the day 3, the quality doesn't look good and doesn't look like they can go for a day 5 culture, those are like certain conditions where we can consider going for a day 3 transfer as well. Otherwise, if we have good number of embryos, definitely it will be a day 5.
Yes, it has been shown that the clinical pregnancy rate as well as implantation rate and your miscarriage rate both are significantly different when you compare with day 6 blastocyst or day 3 cleavage stage embryo. And day 5 always been associated with a better, because you can select the embryo better. You will be able to reduce the miscarriage rate because by selecting it is, and we have that moderate quality evidence available for improving the clinical pregnancy rate by doing a day 5 transfer. That's another important step for optimization. Now, below what cutoff of endometrial thickness there is a significant reduction in CPR and live birth rate in IVF? May I ask to Dr. Padmaja, below what at 80 cutoff you will not do a transfer? You know that there is a significant, though it is not zero, but we are not happy to do an embryo transfer. Padmaja, what do you do in your practice?
Anything more than 7 mm triple line, good vascularity, I do go ahead. But
Yes.
if she's having persistently, that means I try HRT cycle, I try a natural cycle, and it's still staying for 1 or 2 months, then there's no point in trying to achieve that. So then even 6 is there, but less than that, I'm not at all happy.
Dr. Asha, as an expert, I want to know, do you feel that natural cycle proves little better in terms of getting a better endometrial myelu than the HRT cycles? Do you feel by experience that you have seen this?
Yes, I have seen this, and I do agree that many a times the natural cycle or even letrozole induced cycle gives the better endometrium. And then you have to try also. In one cycle, you have tried HRT cycle, it didn't, you're not satisfied with the endometrium, then don't waste the embryos. You can next time try with the natural cycle or with letrozole. And the advantage of natural cycle is you can always add on a little bit of estrogen if it is required. So it really works many a times.
I think that's how the experts answer, and I think I will agree with your statement that yes, there is a better myelu and you can add as estrogen sometimes in a natural cycle. But will you do FET, Dr. Radha, for all patients, or will you prefer individualization? Sometimes you feel according to the response I may do a fresh transfer, or you do FET for all patients.
No, sir, it has to be individualized. So I take into consideration what is her response during the stimulation. Is she at risk of OHSS? I'll take into consideration the endometrial thickness, the pattern. We also have the habit of checking the P4 level. on the day of trigger. If it is more than 1.5, we don't. And if it's a thin endometrium or there's a fluid in the endometrial cavity, we don't transfer.
So we have evidence clearly that majority times freeze all strategy works better for higher responders, and certain normal responders when your estrogen levels or number of oocytes are more than 10 or 12. I think there the FET and freeze all strategy is going to work for all patients, but rest of the patient where you have less than 10 oocytes or all poor responder, probably better to do a fresh transfer. You will have a equally better rate. We have already discussed that natural cycle HRT probably not much difference in terms of, but yes, the measuring serum progesterone level on the day of ET. Dipti, what about you, your practice? Do you routinely measure progesterone levels either one day prior to embryo transfer or on the day of ET to feel that it really helps to improve the reproductive outcome?
Sir, routinely I don't. Again,
Okay.
we individualize, and in majority of the patients, since we are doing the scans ourselves, the endometrial appearance, if it's a good grade A triple line endometrium with good flow, then perhaps we can go ahead with the transfer.
But you, even if you have, if do you follow in certain cases you said that
In
you do
certain cases,
progesterone
yes,
levels.
definitely.
Yes.
Certain
So
cases, yes.
so below what cutoff do you don't do a embryo transfer? Yes, Pratik.
We
Times
need to
is
stop, please.
okay. All right.
Just wind up.
Okay. Okay, so I think let's hear from at least panelists important message when it comes to optimization from each panelist. Then we'll take experts. So Dr. Radha, your message to the audience, please.
Yes, it is a proper selection of the patient, proper protocol, and also good ultrasound monitoring and a good decision of a trigger, like in a hyperresponder, an agonist trigger, and HCG trigger in a normal responder. And also deciding whether for a fresh or a frozen transfer, it has to be individualized. That is one of the key factors for a successful ART outcome.
Dr. Padmaja, your message, please.
Quite a large number of times we listen to one expert read one paper and change all our practice, and I think that shouldn't be there. We should see what is working out for our people, for our client. Look at your own data, look at the history, and don't make radical changes. Make small tweaks and see what is there, because sometimes the IVF cycle that the couple is going to might be the only one they can afford. So look at it from that perspective.
Dipti?
Sir, I think James Clear ka principle of marginal gains. So we have to actually see कि हर segment में हम क्या-क्या improve कर सकते हैं.
Okay, great. Dr. Venugopal, Sini?
That is, apart from optimizing the IVF protocols and the embryo transfer protocols, we can also ask the patient to have a that is IVF cycle lifestyle and proper management of weight and preconception vitamins, to quit smoking, alcohol, sleep, stress, to improve all the other parameters, and then go for the best optimum like IVF protocol and the transfer protocols to give
Nobody
the best
wants to optimize the embryologist and the embryology lab.
lab and the embryology.
They are good, Dr. Pratik.
Dr. Asha, as an expert, what is your message, please?
I think the teamwork is very important. Pre-ART workup is again important, and try to go for some moderate stimulation rather than maximal stimulation. I know these days freeze all policy is there, but still we have to be kinder so that the estrogen levels do not go sky high, and try to go for fresh embryo transfer whenever it is possible. So don't just go for freeze all policy all the time.
Dr. Neelam, madam, बोलिए.
For me, the individualization is the key, and you have to optimize from since very beginning, from lifestyle management to selecting the patient accordingly. And counseling is very important, that how much eggs we are getting, how and what is the condition of sperm, and then and giving them realistic goals.
Thank you very much, all the panelists. A simple message that there are three important pillars. One is oocyte, one is a sperm, and one is endometrium. We have to pay attention to all three factors of each patient and work on those problems in those three pillars. and probably you will be able to achieve the success. I think thanks to all my panelists and experts for giving very crisp and complete answers for my questions, and thank you Pratik for giving me this opportunity to moderate.
Thank you, Dr. Kundan Ingre, Dr. Nita Mori, and Dr. Asha Bakshi. Fantastic panel. Thank you all the panelists who logged in. We are already 13 minutes late, and 700 people are screaming for the link. So Shreya, please post the test link and please post the QR code and share it so that we can proceed.
Congratulations to the team. So much attendees, so many attendees are there.
Today
Congratulations.
actually we have less, ma'am. The first day we had 950.
Okay, great.
Excellent.
So the test link is posted in the chat box. All of us will continue chit-chatting. So in case our chit-chat is disturbing you, please reduce your device volume. Dr. Kanti, you want to present the vote of thanks formally?
Yeah.
As the
Thank
coordinator
you.
for today?
Yeah, thank you, Dr. Pratik. Thank you, Dr. Sheila Mane. She's busy as
No,
usual.
she's listening.
And all my other friends. Thanks all the experts, the faculties, and the delegates. Delegates have shown so much of faith and appreciation, and they have been learning all the 3 days. I think truly it is a masterclass in infertility. Once again, congratulations to Dr. Sheila Mane, Dr. Pratik, and all of us. Yeah, and I wish we have more and more of such. It indicates that the delegates
It's all
want
teamwork, and I'm really grateful to everybody who contributed, all of our governing council members. Like I said today at the beginning, there are many who don't practice infertility, but they made it a point to come and log in and make their presence heard. I really
Yes.
appreciate that.
Yes. Thank you so much.
Thank you all, Kanti, Ritu. Oh, Padmaja. Thank you, Padmaja. Excellent
Padmaja is doing the
panel.
post-test.
Excellent panel.
We missed the complete panel because of short of time.
No, but still they got 40 minutes.
Yeah.
Even yesterday, the panel ran on for 40 plus minutes.
Correct. The topics were also very nice, selected
The
well.
topics are very practical and they are aimed at the general PGY.
Bega pen kodu.
So I think everybody appreciated that. There were a lot of questions in the chat box. I was also answering a lot of them personally.
And the best part was it was seamless. Everything was so correctly done. I think Pratik, you need applaud.
Just the backbencher. Doing work in the background.
I wish we were all backbenchers.
Take her number. I have told her 96641.
But there's a lot of satisfaction after such a webinar. Really.
The mammoth fast. 3 days is a mammoth.
We are really thankful to all of them. We are getting, they really log in good numbers, and some people are complaining they're not able to know. Pratik, we have to really see to it,
Yeah, some of them are saying they didn't know how to come to know about. Yeah, I read that.
So many of them have messaged me. Many of them have messaged me, and I have added them to the ICOG broadcast group.
Correct.
And
So
they can
now
share the same
we are
link with
making
their
a
friends.
broadcast group, but that is for FICOG. We send it to president and secretaries. They have to share it in their society.
But not every president, secretary are proactive.
So it is really, Pratik, we have to really brainstorm that,
Yeah.
That how do we reach?
So we'll have to create a broadcast of all 40,000 people.
But that FOGSI will have to do.
Exactly. We'll have to speak to Suvarna about it. If I meet her tomorrow, I'll speak to her. But I don't know if she's coming to the office tomorrow.
Yeah, please do that.
Yeah.
That will be better. Otherwise, people really miss it.
No, there are some things which can only be done in person, like I say, when you're physically in the office. These things can't be coordinated on the phone or email. So Dr. Nova Shinde has is done. Archita Chawla is done. Mansi Atreja is done. Usha Goenka, very good. Shraddha Maheshwari, Zainaba. There are so many people I am seeing for the first time. I'm getting to know their names. Devdatta Dabholkar. Ishika Nain.
Ramya Shankar is trying to get in, allow her to get in. She's just logged out and not able to come. The backend team just check.
There is no waiting room now.
Oh, that is the problem again.
Anita Kuruvilla, you will get the recordings on the ICOG website after a week. Rishi Rawat is done. Darakshan Abbas is done. Lavanya is also done. Palak Mehra.
There are still 635 participants till now.
Yeah, we were expecting around 700 today and we have that number.
No, but till the fag end of the webinar, still there.
But we want to know, but people want to know the answer also, no, madam. So they will wait for the Dr. Pratik to tell us the answers.
Yes, correct.
No, I feel sometimes quizzes, no, like unless we have to put it in word exactly the choices, you don't know whether we've understood it or not.
For all 3 days, Dr. Padmaja, you'll be surprised. I have put in the easiest MCQs. I mean, something that a 5-year-old child will be able to solve. He doesn't even need to know reproductive medicine. Very basic, simple questions. No, seriously. You look at the questions and you will realize.
Dr. Pratik, there are 2 questions in each MCQs which are
Pratik,
a little this thing. The others are high. You wanted everyone to pass. That's the good thing.
Yeah, so I always put in simple questions. The difficult ones are put in by other people. Dr. Gitanjali, please message me. I will send you.
I always feel life should be in moderation. So with these antag cycles, sometimes when we give the antagonist, the LH is so low, and then the trigger
Over suppression.
Over suppression, especially when on the day of the trigger, when the LH is less than 1, that is when we will get empty follicles. So
could be, yeah.
So doing an LH, looking at the E2, I feel still on the day of the trigger, it makes me happy. At least we can avoid that.
And I also feel people should not be so scared of OHS. And nowadays, the newer students and newer people, they're so apprehensive about OHSs. They should opt a fresh cycle whenever, where there are very few oocytes or few
So
embryos.
say hi to me in Ankarstin in Gelinko.
So they should give HCG and, we get good results. I was so excited recently to do a fresh transfer.
And Dr. Kanti, we also see the other extreme where people are so confident about doing a freeze-all and with the use of letrozole and all for that there are 30 follicles in each ovary. So I feel we shouldn't go to that extent also, like telling only once I'm going to stimulate and then I'm going to nail it and get 15
So
embryos.
Christoph used to call this wild stimulation.
Yes.
If you know Christoph.
Too much is too bad. And too less is also too bad, but too much is, at least in our IVF, too much is really too bad.
Yeah.
So you'll get the certificate by email once all the results are collated and the backend team has a chance to review all those 1000 plus records. It takes time. It's physical work. It's not AI. There are human beings doing it. So it takes time. Please be patient and hold on to your horses. Thank you for the appreciation, Dr. Srinarayana, sorry. Thank you, Dr. Vidya Kulkarni. Thank you, Dr. Gunjan.
Even in the chat box, so many questions.
That shows the interest, the growing problem, infertility. Your 50% of OPD is that only.
Dr. Priyadarshini, as long as you've logged in with the same email address, the hours will be counted. It's not the device that matters.
So dear all, the next month we will have a master class on immunology. Very interesting.
That is very interesting.
I'm going to get immunologists from all over the country. Okay.
Achha.
So that is the one. And the certificate course is on AUB.
Achha.
Okay. Guru Mantra, we will have Dr. Sanjay Gupta and Dr. Atul Munshi sir. And rest will be 3 PG programs. Apart from that, we have
PG Clinic, Gurukul, research methodology.
Yeah. And 7H programs. Kanti, you must start in Gujarat.
We do that.
Okay, because now Delhi, Noida are doing, UP has started. Padmaja can do in Andhra. Okay. We'll let you know.
Yes, madam.
Yes.
Okay. Yeah.
I
Thank you,
think Dr.
Chita.
Sheila and Pratik are not sleeping in the night also.
No, we sleep very well. 7 hours later. We are
6 hours
exhausted by the end of the day.
6 hours is enough for me. Okay. Still there are fun. And dear all, we are all going to share the HTTP survey link and the pass registry link shortly. All of you, please participate. We will create a great data from ICOG. Okay, we are really working hard for that. How to apply for FICOG? Okay.
I have sent them the link.
Log into website.
There's a question, Dr. Sheila. The 30-year-old obese PMOs with insulin resistance, AMH 7.5, possibility of spontaneous conception. So, if they're ovulating and there is a normal male factor, there will always be a possibility of spontaneous conception. What happens in obesity is the adipotoxins that are coming are acting as reactive oxidative species and are not letting the antral follicles grow, and they're suppressing it. So you have a low AMH. So they're having double whammy. They're having a metabolic syndrome. They're having insulin resistance. They will be having a little amount of hyperglycemia, and they have ovaries that do not want to ovulate and make her pregnant because the baby is going to be exposed to so many more risk factors in this pregnancy. So that is, I feel, one of nature's way of telling you have to improve your lifestyle to become pregnant.
So the ovaries are adamant.
Yeah.
That's what I tell my patients, even of PMOS.
All of you can check your emails. FOGSI sends email.
I did not get Dr. Sheila.
That is what I tell Nilima.
I have received it. Today I received 3 emails, one for placenta accreta spectrum, one for FOGSI ICOG Jogi research methodology, and one for the ICOG Guru Mantra. 3 emails I have received today.
That is certificate. What I am saying is, Pratik, when FOGSI sends email to all regarding our program, that is not reaching everybody.
That may be because sometimes certain batches may not be getting delivered. That may be the issue.
So that is why now people...
When they send 25,000-30,000 emails in one shot, owing to server overload, some of the batches may not be getting
we have to
delivered. That
really
is a
think
known.
about it, no? That how
That's
we
exactly
make
why I
it.
said we need to have a phone broadcast.
अरे बाबा वो 45,000 का कितना broadcast बनाएंगे?
We have to send only 5 messages or 6 messages in a month.
No, that is okay. FOGSI के भी रहेंगे ना. I am saying the groups, how many groups to make? You will need people.
No, it will not have to be as a group. We'll have to go through a third-party provider.
You know better.
Yeah, we'll have to go through a bulk WhatsApp.
Talk to Suvarna tomorrow.
I'll speak to her if she's there in the office.
She will be, no? I think I spoke to her today.
There's one question, how AMH is related to endometrial lining. I don't think it is directly related to endometrial lining.
Yes.
When you have low AMH and you have no ovulation or anovulation for a long time, you're going to get a chronically thin endometrium. That is known. You'll get an infertile uterus, it'll be shrunken, there'll be no baseline estrogen. That's what's going to happen.
ಮತ್ತೆ ಎಲ್ಲ patients को ಕಳಿಸಿ.
If you have MICOG, yes, of course, you can apply for FICOG, but you need to fulfill the criteria. You need to be 10 years. So there's less than 1 minute left. icog.engage.co.in, or you can get the link from the ICOG website, icogonline.com. Somebody has received certificate for pass. Very good.
Is there a Zoom ad on the thing going on my
Yeah, she's
screen?
just shared her browser. She'll share the PDF also now.
Okay.
She's just waiting for the timer to count down.
Yeah.
Shreya, time is up. You can share the PDF, please. Backend team,
Yeah.
answers.
Yes, sir.
Dr. Ritu is not there, so Dr. Kanti can do the first 10. I will do the next 10. Please go ahead, Dr. Kanti. Only give out the correct answers. Don't read all the options.
First one, which IVF add-on currently has the strongest evidence for routine improvement in live birth rates for most patients? None of the above. And embryo glue contains, इसका आंसर ही नहीं है.
Hyaluron rich transfer medium, madam.
It's hyaluron.
Hyaluron. Then calcium ionophore is used for artificial oocyte activation. A major concern regarding IVF add-ons is answer is lack of evidence with increased cost burden. Which IVF add-on has been given a black traffic light by the HFEA for routine improvement in live birth rates? PGTA. What couple should be referred earliest for ART? Answer, woman age 39 year with infertility for 8 months. अच्छा question से. Before planning IUI, which investigation is essential in the female partner? Tubal patency, that's a B. Which is the lower limit of semen parameter which is generally considered essential for IUI? Total motile sperm count of 5 million. Which condition is commonly treated with IUI? Mild male factor infertility. A patient with severe endometriosis is generally better treated with C, that is IVF.
Okay, I'll do the rest then. Question 11. Which statement about early IVF referral is correct? The answer is B. Early referral may improve pregnancy outcomes. Question 12. The most common indication for ICSI is what it was originally devised for. That is B. Severe male factor fertility. Still holds true even today. Question 13. Early referral to ART may be considered in a case of. The answer is all of the above. OAT, advanced maternal age, and stage 3, stage 4 endometriosis. Question 14 is day 5 embryo transfer involves blastocyst. It is not the other options. Question 15, pre-cycle investigations include all the investigations that are mentioned there, TSH, prolactin, and AMH. Number 16, elective single embryo transfer is recommended to reduce multiple pregnancy rates is the most appropriate answer. Number 17, stimulation protocols commonly used in ART include all the protocols. I think Dr. Jyoti gave an excellent overview of those, so you already know the correct answer. Question 18, luteal phase support in ART includes progesterone, which is the most appropriate answer, though estrogen is used sometimes. And cabergoline is occasionally used, but only in case of patients who are hyper-responders, where you would not do a transfer any which ways. Progesterone is the correct answer. Question 19, the best route for vaginal for progesterone support is intramuscular, which is considered as the gold or platinum standard, though the other routes are very close and achieve 90% efficacy as compared to intramuscular progesterone without the side effects of the same. As per ART law, the following are legal. It is donor egg IVF. IVF cycles for gay couples and foreigner couples are no longer permitted in this country since several years now. Thank you very much, everybody, for participating in the 3-day infertility course conducted by the ICOG. My gratitude to our chairperson, Dr. Sheila Mane, for giving me and Dr. Sarita Bhalerao this opportunity to convene this fantastic course. We had 950 plus attendance on the first day, over 800 on the second, and today we had almost 700 people. Thank you very much to all our course coordinators, all our faculty, the chairpersons, moderators, experts, panelists, and of course the speakers who gave their precious time and shared their knowledge with all of us. Can I request Dr. Sheila Mani to give us the closing remarks?
I think I'm so happy, the response, and I'm seeing the interest develop in the delegates. You know, there are so many questions they're asking that how to become. I mean, academics is so important, Pratik, and I'm happy that we are able to reach to them. Okay, so one more thing we'll do now regarding the conference also or ICOG details. When we send the certificate to them, let us attach these things and send it to them. And those who have already attended, I think if we can share the every month program with them, already we will have their email IDs and we'll request them to spread this news. So at least the email IDs we have collected for over a period of 6 months, those who have attended all the programs, we can directly send it to them. So that will be easier and we will find out the way. So this is the fellowship criteria, dear all. You can just take the picture. And we have a convocation in Bangalore on 22nd August as well as in AICOG in Surat. Okay, so try to come in big numbers. Also come for the conference. Recording will be available after 1 week. Thank you, Kanti. Thank you, Ritu. Thank you, Padmaja, for being there. Thank you, the backend team and everybody, Nilima, Poonam, everybody. Thank you all.
Thank you, Nilima, Poonam, and Shreya, for all your hard work behind the scenes. Until next time, everybody.
Congratulations, congratulations, Irfana. She is our regular attendee.
Thank you, Dr. Pratik, for all the help.
Thank you, ma'am. Thank you for all the hard work.
For the backbone.
Yeah. Thank you.